organizing chairperson, Dr. D.P. Singh, to please join us ahead, along with the scientific chairman, Dr. Hem Shankar Sharma. Can I also request the principal, Dr. Ashok Bhagat sir, to please join us, along with our superintendent, Dr. Uday Narayan Singh, to please join us. We also have our organizing secretary, Dr. Obaid Ali, and Dr. Manish, and Dr. Abhilesh Kumar to please join us as he's the HOD Medicine. And lastly, can I also request Dr. Manish Kumar to please join in? Everybody can give a big round of applause as that starts with the. I would also like to update you. Our first three speakers are here. They've also uploaded their presentation. And this time it's going to be an on-time Bapicon so that everybody can enjoy the evening as well. The, the organizers have made sure that the evening is as entertaining as the day it is. Please follow the schedule to ensure that the talks are in the same hall. Yes. थैंक यू सो मच. अब ये जो फोटो है सबके फेसबुक और इंस्टाग्राम पे जरूर मिलेगा. थैंक यू. With that, can I request our organizing chairman to please say a few words?
Welcome friends, the inauguration ceremony of workshop of Bapicon and Ezapicon 2023 to be held today in the precious this background or this Jawaharlal Nehru Medical College campus, and the principal is Dr. A.K. Bhagat, who is going to inaugurate, and request him to say a few words.
अंक की इस धरती पावन धरती पर बाहर से आए सारे डेलीगेट्स स्टूडेंट्स का स्वागत है हमारे जवाहरलाल नेहरू मेडिकल कॉलेज के प्रांगण में. धन्यवाद.
बिना किसी संबोधन के इस आयोजन को सफल बनाने की शुभकामना देता हूं और अपने पीजी इंटर्न्स वगैरह जो लोग इस आयोजन में भाग ले रहे हैं वो इससे बहुत लाभान्वित होंगे. धन्यवाद.
Good afternoon, everyone. As a scientific chairman, I, Professor Hem Shankar Sharma, welcome you all, and I send my good wishes to all the postgraduate students particularly to come up, learn, present their cases in the best possible way, interact with all of us, those who are seniors over here, and you just listen and get the benefits from all those who will be coming after few minutes over here. Thank you. Now, may I request my friend Professor Abhilesh Kumar, HOD Medicine, to say a few words.
I wish all the success of Bapicon Galaxy of Bhagalpur. Thank you.
A few words, Dr. Manish. Okay. Dr. Obaid Ali, our organizing secretary, has labored very hard to make this conference a big success.
Thank you, sir. As an organizing secretary, I welcome all the faculties, delegates, postgraduate students, pharma people, and press in 3 days Bapicon and Ezapicon 2023. Thank you.
So,
long live API. Long live API.
Thank you so much. With that, the inauguration ceremony comes to an end, but the beginning of the workshop. To get started with the first talk, can I request our chairpersons to please join us? Our first chairperson itself is Dr. B.P. Singh, Dr. Sanjeev sir, and Dr. Sanjeev Pandey, Dr. Kumar Saurav, Dr. B.K. Sharma, and Dr. R.P. Jaiswal. Sir, aap chairperson hi ho. And I think that would be very lucky. Can I request our first speaker, Dr. Partha S. Karmakar, to please join us on the stage? Yes. With the... Yes.
So, the opening batsman of this mega event is none other than my friend Dr. P.S. Karmakar coming from Kolkata. Where is the slide? Okay, okay. Just, yeah. So, Dr. P.S. Karmakar, he is a professor of Department of Medicine, College of Medicine of Kolkata. Please, please. And he is a great scholar, and he is the opening batsman, and he will open up the diya deep of knowledge. And the topic is immune senescence with aging. And what is this immune senescence? When we age, as old as we are, 70, 80 or whatever, and how to tackle it and why to tackle it. Over to Dr. P.S. Karmakar. Please welcome him, giving him big hands, and so that he can make century just like Virat Kohli and others.
Virat Kohli is not opener, sir. So, yeah,
And-
jokes apart. So, I'm thankful to Dr. D.P. Singh for all those kind words. I don't know whether I deserve all those kind words or not. So, respected chairpersons and the learned gathering present over here, I'm really thankful to all the organizing team members, in particular Dr. D.P. Singh and Dr. Hemshankar sir, for giving me this chance to have discussion with this learned gathering on a very important topic, that is your immune senescence with aging, why and how to tackle. So, immune senescence with aging, I will take you through this important topic by briefly touching upon the basics of immune system. This is just recapitulation. What changes do occur with immune system with aging, and can we delay and tackle the process of immune senescence and take home message? So, we all know that our immune system is giving us a defense against the microbes, but not only the microbes, they also give defense against foreign substances and damaged cells by clearing them, like toxins, chemicals, foreign particles, allergens, dead or dying cells, as well as tumor cells, cancer cells, not only the virus, bacteria, fungi, and parasites. So, you will be boasting of your status of successful immune system if they can serve the following functions in your body. If they can recognize and respond a wide range of potential targets, that is antigen, to the tune of 10 lakhs to 100 crores, that is 1 billion. And there is so much of variety, because of that depends upon our lifestyle in our early childhood. How did we maintain our early childhood? That depends how much we are exposed to that antigen. Now, selectivity, that is very important, that your immune system must be able to differentiate between self and non-self, as well as invasive bacteria and normal flora. Otherwise, harm will occur inside your body. And the presence will definitely be systemic. All your systems will be protected by your immune system. And one very important, that is last but not the least, the action of the immune system must be delicately regulated. There should not be any runaway or excessive immune system, which could be very much harmful, as does occur in second times of dengue or the cytokine storms of COVID-19. We are aware of that thing. So if you do have this successful immune system, their functions could be divided into two very basic things: innate immune system or primary immune system, or adaptive immune system or secondary. Primary immune system, that is innate immune system, is the immune system with which we are born. This is the first line sense. This is the first line defense and defense against microbes, and they don't have any memory cells. They all the time behave in a similar way to all sorts of targets they are invading our body. So 4 types of cells are there to subserve this immunity. These are dendritic cells, macrophages, neutrophils, and natural killer cells. These 4 cells are performing the part of innate immunity. So I have already said they are the first line of defense. And on the other hand, the adaptive immunity, they are very skilled players. Their action is very focused. They are super specialists. They only act against only one antigen. Okay, and this is being served by B cells and T cells. So, and adaptive cells does have the memory of previous infections, and these memory cells come and they show their focused action only against one antigen. So how these B cells work? So B cells develop and mature, we all know, in the bone. B is for bone. An antigen receptor, that is the B cells, that is antigen receptors, are nothing but the specific antibody. And whenever they are being attached with some specific antigen, this sort of very specific B clone proliferate and give rise to humoral antibody that is being sprayed to tissues and blood. So this way the adaptive immunity works. Then similarly, like that of B cells, T cells also functions cell-mediated adaptive immunity, and they function in the same way, but their function is cell-mediated. They also act against only one antigen, and once activated by antigen, T cell will multiply and they will produce their cytotoxic effects. So really we know that if the wine becomes older and older, they become dear. So as we ages, our age advances, our immune system is also becoming dearer and dearer. You have to protect it very carefully to get protections from the infections and other cancerous cells and to keep ourselves healthy. So how our immune system changes as we age? Actually, what happens, aging affects all parts of immune system, both the adaptive as well as your, the primary immune system or immune system. And our immune system steadily declines as we get older. And mortality, and as we get older, and if our immune system steadily declines, increased risk of morbidity and mortality due to infections does occur. And chronic, and along with these infections, there is another very important part that plays a very important role so far aging population is concerned, that is persistent chronic state of low-level inflammation. That also goes hand in hand with declined immune system and push ourselves, the aged persons, towards the condition of frailty. I will come to that in my later slides. So what happens? So both the adaptive and the innate immunity is coming down with aging. They become slow, sloth, and sleepy, like this. And whenever some antigen comes inside our body, immune surveillance may fail to detect it. This antigen is not being detected by this slow, sloth, sleepy soldier, which was active, alert, and dynamic when in young adults. So they fell. So what happens? The more vulnerable, we become more vulnerable and more susceptible to infections because immune surveillance to many of these antigens are being failed by innate immunity. So the same things happens to our adaptive immunity as we are aging. So adaptive immunity, I have talked about that depends upon the activities of the B cells and T cells. So bone marrow cellularity decreases, so B cell population decreases. New B cell formation is greatly reduced as we are aging, and the relative increase of the memory B cells occurs. And if these B cells actually becomes autoreactive and they multiply out of control, they can produce another disease that we all know, that is MGUS, monoclonal gammopathy of uncertain significance, and if that is much more applying, then they can give rise to development of multiple myeloma. So that's why regulated action of the immune system is very, very important. Similarly, the T cells also, the same thymic involution has occurred because the T cells get matured. It starts its life in the bone marrow, but it gets matured with the in the thymus, as well as the lymph node growth factor also helps maturations of the T cells. So if there is defects due to thymic involutions, as well as if there is some deficiency of the lymph node growth factors, that the same things happens as it happened to B cells. The memory cells gradually, they are temporary increment of the memory cells compared to the new T cells, which are really being formed to in a grossly reduced number. So reduced number of new T cells and decreased diversity of antigens recognized, because they sometimes fail to recognize trafficking. There is problem in the trafficking and surveillance of the immune system, and relative increase in memory cells and we are really being more prone to develop infections. So there is plethora of antigens in the blood or tissues, but there is scantiness of both innate as well as adaptive immunity cells. So there is some latent chronic infections that increases the inflammations as it is already persisting in aged persons. Now coming to the inflammation, how it further deteriorates our reduced activity of innate and adaptive immunity. So inflammaging, what happens actually? So some of us gives very much importance to this. So age-related increases, there is low-level pro-inflammatory molecules all the time in the blood and tissues. And this persistent, chronic, low-level steroid inflammation, what it does, it ultimately gets associated as with our aging, that is osteoporosis, atherosclerosis, type 2 diabetes mellitus, and cardiovascular disease. So these low-level persistent steroid inflammations, along with reduced activity of our immune system, push us towards the condition of frailty. And what is frailty? You all know frailty is nothing but a lowered hemostatic reserve and increased vulnerability to stressor events. So this sort of inflammaging due to old age, as well as lowered activity of innate and adaptive immunity, leads to loss of control of latent infections. So aging person may appear apparently healthy, but low level of inflammations is going on and loss of control of latent infections. So there is another important thing because of the inflammaging. What happens, you have heard so many words down the lane for last decades about the gut microbiota. So gut microbiota, as we age, the beneficial microbiota in the gut gradually reduces and the proportions of pathogenic bacteria increases. And thereby the toxic materials from the pathogenic bacteria translocates through the disturbed gut mucosa, because they become leaky due to inflammation, due to age, and become systemic. So you all know gut microbiota plays a very important role in prevention of so many diseases, neurological, starting from your Alzheimer's disease to IBD, IBS. So all these things get altered due to the changes in the gut microbiota and leaky gut. So all these things help together, they work hand in hand to make ourselves more frail, more vulnerable to develop infections. So inflammaging, what it causes actually, then you have to think about your status, your body stature, as well as your activity. If your body fat is more in the central part, that is abdominal obesity is there, and you are inactive, and gut barrier dysfunction is there, and decreased response and low level of inflammations and loss of control of infections could give you a burden of pro-inflammatory adipokines or cytokines. There are also in our body some anti-inflammatory cytokines, and that comes from lean muscles, tissues, and from your active lifestyle. So active lifestyle, and if your muscles work, that anti-inflammatory molecules to some extent combat the pro-inflammatory adipokines and lipokines that comes from a elderly, obese, central obesity persons. But this thing doesn't happen to all, majority of the persons. So the pro-inflammatory adipokines is more. And if there is inflammations goes on, what it happens? It produces insulin resistance, cardiovascular diseases, sarcopenia, chronic kidney disease, neurodegenerative disorders. So chronic level of persistent sterile inflammations along with low level of infections that goes on in the elderly people is actually responsible for all these diseases. So what can we do about it? Can we tackle or can we reverse these immune senescence? Let us see what happens. This is whether we can tackle it or not. It is an active area of research, and lots of things we have learned from immunotherapy for cancer, because they have achieved a great success through immune modulation, manipulating immune system to fight tumors, upcoming cancer vaccines, and personalized medicines. So all these categories can we use. Can we similarly manipulate our immune system to combat immune senescence and inflammaging? Which are these two things working hand in hand? Yes, definitely to some extent. What we can do, we are very much negligent, reluctant about adult immunization. So vaccine responses, we have to start vaccinating ourselves as well as our patients to maintain, to stimulate our declining immune system. So vaccine response, you have to keep in mind also that thing, that vaccine response is not that not that active. It is lower in the elderly, and so you have to keep up to date so far vaccination is concerned in elderly people. It is really very neglected still as of today globally. And strategies to overcome lower responses, what we do because of the lower responses, what we do face in elderly persons is in relation to that is you have to give more immunogenic vaccines. That is 4 times amount of antigen could be given in a single shot that is being happening in influenza vaccine. And we all the time keep ourselves content whenever we are prescribing influenza as well as pneumococcal. These are 2 being used, but these are 2 will not suffice so far our stimulations of immune systems of the elderly persons are concerned. Why? Because we have to think about, because there are, you all know that top 10 diseases which could be prevented very well through vaccinations. So not to restrict yourself with only influenza as well as pneumococcal vaccines, you have to think about, time is over or is 2 minutes more? Okay, I will try to wind up. Now, 2 doses, that means there are some other vaccines apart from the influenza and pneumococcal. Singles vaccine you have to think about, and the new singles vaccine is effective to the tune of 97%. Then another vaccine, pneumococcal, I have already said that PCV, pneumococcal conjugate vaccines, or pneumococcal polysaccharide vaccines also available. Now coming to the another vaccines, tetanus, diphtheria, and pertussis. Tdap. Tdap means tetanus, diphtheria, and acellular pertussis. That is to be also considered in persons above 50 years of age. And every 10 years, once a person has taken above 19 years Tdap, only you go for TD every 10 years. Now coming to the COVID-19, we are very much acquainted with those things, with all these things, and messenger RNA virus is the best among the COVID vaccines. Now coming to the same cartoon once again. So if you can maintain your body stature, less amount of body fat, and active your muscles, thereby increasing anti-inflammatory molecules more, so you can be having that sort of beneficial effect, you have to be very active. So your immune system is adapting and restructuring as you age, and physical activity has a positive effect, very, very positive effect on these changes. And through physical activity, you can reverse many of the age-related changes in the immune function, just to make yourself more active. And you have to go little bit of aerobics, some resistive exercise, some dancing, or some other physical activity. This is the simple things and simplest but the best things to achieve your immune system to be active to the tune of your young adults. So 1 minute more. Widely accepted physical activity has an anti-inflammatory effect. There is no doubt in. Inactivity is known to be associated with systemic low-grade inflammation. So be active and try to reduce your pro-inflammatory molecules. So take-home message is both innate and adaptive immunity is compromised as we age. And less immune surveillance in elderly makes us more prone to develop infections. And out of this infection, increased mortality, and mortality is there. and lessons from success cancer immunotherapy, we have to try that immunotherapy for aging is being studied also, and we have to use in rejuvenating our own senescence immune system. To stay up to date on vaccination, not to neglect, not to be casual about vaccinations of the adult persons and elderly person, and maintain regular physical exercise to tackle inflammations and frailty if you cannot reverse it. Thank you for your patient hearing. So I take the opportunity of inviting you all in adult immunization that is going to be held national conference in Kolkata on 20th and 21st of January. I am one of the organizing members over there.
Hello,
So
hello.
adult immunization is really
Over to the
lacking today.
chairpersons. Yes.
Over to the chairperson.
Excellent talk, Dr. Partho Karmakar, as we
Thank
have
you, sir.
expected, and the message is very clear cut. But still, at the age of 70, as I am, what vaccine you will advise?
So at
Except for, yeah.
Definitely. So probably you have already taken pneumococcal vaccines. After this age of 65 years, pneumococcal is indicated for all of us. If we take pneumococcal conjugate vaccines, PCV20 is available. If you take that vaccine, then no need of PPSV, polysaccharide, pneumococcal polysaccharide vaccines. But if you don't take, if you have taken 13, Prevnar 13, which is available trademark, so if you do take Prevnar, then you have to give a booster of PPSV 8 weeks to after 1 year of that PCV13. But PCV20 is now available if you continue. Another yearly is your influenza vaccine after 50 years. And then as you are 70, so you are more prone to develop shingles and everything, definitely you should go for shingles vaccination. But the problem is it is made by GSK, it is a bit costlier. That is not the problem for you. I am talking about the general population as well. It is costing around 9 to 10,000, and you have to give 2 doses at 2 to 6 intervals. Okay, but nowadays what is available, that is the subunit, protein subunit vaccines along with one adjuvant. So that is 97% effective. And many of you will definitely be of same opinion that nowadays after COVID, we are seeing more persons suffering from shingles in elderly people, what we didn't see in pre-COVID era. And another important thing, you should also continue the Tdap. So top 10 vaccine preventable, you should take at least 7 vaccines for keeping your health. You are very healthy, even more than me, sir.
Yes, sir. With respect to the next, yes.
Yeah, no, yeah. So one question, house is open for question. One question will be allowed. Yeah.
Yeah, thank you.
You have mentioned that I think there are 3 pillars to make the immune system booster.
Yeah.
One is the balanced diet, which you have not mentioned.
Right.
And second one is the physical exercises. And third one is, the third question is, if your immune system, they agreed with the aging process, the immunity downgrading. But you have said that memory cell is booster, memory cell is increased. So if you are giving the vaccine, the memory cell will again become active. This immune, right, that you had to explain me, sir.
Yeah, thank you for this question, very pertinent question. What I have said, that relative increase of memory cells, that means what are the new T cells, new B cells are not increasing to that extent what is expected. But the memory cells are present, suppose it is 10. In young adult, the new T cells, B cells was also 10. That ratio is not maintaining. Memory cells 10 coming down to 8, but the new T cells and B cells coming down to 2. So there is relative increase in the memory cells, but we need to produce more and more new T cells, B cells to tackle many more different unknown targets. That's why the COVID was very much dangerous for the elderly people, because we are not acquainted to that target, that antigen, but new T cells, new B cells are really lacking. That's why that was really producing.
Wonderful. I would just like to interrupt here because we're running short of time, and I would request the chairperson to please invite our next speaker. Yes, please. Thank you so much,
Over
sir.
to Dr. Shaw.
Thank you so much, sir. Dr. Partha, thank
Now
you
I
so
will call
much.
upon Dr.
Yes.
Jyoti Prakash. एक ब्रीफ हिस्ट्री, ये मेरे पीएमसीएच में मेरे एमबीबीएस में भी जूनियर थे, पीजी में भी जूनियर थे, और हम लोग की ट्रेनिंग डॉक्टर विजय प्रकाश सर के अंदर में हुई थी. होपफुली कल उनसे आशीर्वाद भी मिल जाएगा. और अभी ये प्रोफेसर एंड एचओडी मेडिसिन है ना एम्स में. नाउ आज उनका टॉपिक है किडनी, क्रॉनिक किडनी डिजीजेज.
Just to let everybody know, the total time is 20 minutes, out of which 17 minutes is going to be the talk time, and 3 minutes is for interaction. The buzzer rings at 15. Please, Dr. Jyoti, over to you.
Good afternoon, chairpersons, respected Professor D.P. Singh, organizing chairman, organizing secretary, Professor Hem Shankar Sharma, Professor B.B. Thakur, eminent professor, and many more faculty of general medicine of Bhagalpur Medical College, Dr. Bharat Bhushan, and many other medical college faculties, dear students, delegates, press media, electronic media. Today's topic of discussion is CKD diagnosis and management. CKD is a global health burden, and in next 15 minutes I will try to complete my speech so that one may be able to easily diagnose CKD and manage it at that time. इसको आइए इधर आइए, यहाँ आइए आप, इसको ठीक करिए, कहाँ से जाएगा, स्लाइड शो करिए, ये यहाँ से नेक्स्ट करिए ना, करिए ना,
ये वाला सिर्फ next यहाँ से.
okay. So what is CKD? Definition of CKD: abnormality of kidney structure or function or both, lasting for more than equal to 3 months. This is the criteria of CKD. A structural defect or functional defect or any abnormal urinary sediment which lasts for more than equal to 3 months, this is CKD. And it is classified on the basis of cause, GFR category and albuminuria stage into 5 stages as depicted in the next picture. This is KD classification updated. Stage G1, G2, G3, G4, G5, and albuminuria stage is A1, A2, A3. So it is clear, stage G1 means GFR more than 90, stage G2 90 to 60, stage 3A 59 to 45, stage 3B 44 to 30, stage 4 29 to 15, and stage 5, which is called ESRD, end stage, that is kidney failure, is less than 15. So every CKD is not kidney failure. It has so many stages. So if, meaning kidney failure, it means it is stage 4 or 5. And according to albuminuria stage, we define as A1, A2, A3. Now coming to pathophysiology of CKD, any cause which leads to CKD leads to ultimate decreased nephron number, and counter effect, there is a structural and functional change in the surviving nephrons. Remaining viable nephrons will hypertrophied, leading to increased intraglomerular capillary pressure, which leads to accelerated sclerosis of the remaining nephrons, and that is a CKD. These are the risk factors: systemic diseases such as diabetes, hypertension, nephrotoxic drugs, viral diseases such as HIV, HBV, HIV, HCV, autoimmune diseases such as SLE, old age, male family history, ethnicity, premature birth, increased BMI, prior AKI. If somebody has insult of prior acute kidney injury, he or she has more propensity towards CKD in later course of disease. If another insult he suffers, preeclampsia, kidney donation. If somebody has received donated kidney, then he has only one kidney, that will have to effect work more than the previous stage. That's why it is chance that after 10 years or 15 years that patient may be suffering from nephropathy. That is another risk factor. Persistent asymptomatic microscopic hematuria, smoking, unhealthy diet, and physical inactivity. Certain viral infections, HIV and COVID, which have COVID nephropathy, recent term. Hivan is a older term nowadays. And these are the leading etiologies of CKD. The number one worldwide is diabetic CKD, diabetic nephropathy. Second is glomerulonephritis. Third is hypertension. Fourth, ADPKD, and rest are other cystic and tubulointerstitial nephritis. There are 4 methods of calculation of GFR. For clinicians in the ward, CG formula, Cockcroft-Gault formula is quite easy. 140 minus A's divided by 72 into serum creatinine, multiply by 0.85 in case of females. Another equation is MDRD. इसमें जब weight नहीं आएगा, age आएगा. CKD-EPI equation and inulin-based method, which is gold standard but cumbersome. KDIGO practice guideline says for estimation of GFR, wherever possible cystatin C is superior than serum creatinine. But if serum creatinine, cystatin C is not available, that facility is not available, then we can go through the equation of serum creatinine. Now the clinical manifestation of CKD usually asymptomatic up to stage 3, sometime up to stage 4. समझ में नहीं आएगा उसको CKD है, आराम से चल रहा है, सब कुछ कर रहा है. When stage 4 or 5, at the stage 4, patient develops fatigue, anorexia, nausea, memory impairment, insomnia, generalized pruritus, menstrual irregularities, decreased libido, pericarditis, hypertension, features of volume overload, and encephalopathy in advanced stages of CKD. Then we go for laboratory investigation to confirm the findings. And the findings are anemia. Anemia develops from the stage 3 onwards. Stage 1 to no anemia. Anemia is usually normocytic, normochromic, but associated iron deficiency anemia may be there in CKD. Electrolyte imbalances such as hypernatremia or hyponatremia or hyperkalemia. Metabolic acidosis is there. Disorders of calcium and phosphate metabolism such as hypocalcemia and hyperphosphatemia. Raised, normal or decreased IPTH. Low calcitriol. Persistent proteinuria. Abnormal urinary sediments such as broad waxy cast may be there. Now coming to imaging, the commonest and easily available is renal ultrasound. We expect bilateral contracted kidney, but we may not get in all cases because this is a finding in the stage 4, 5. In stage 1, 2, 3 of CKD, you may not get contracted kidney. There are few exceptions: diabetic nephropathy, ADPKD, Hivan, plasma cell myeloma, amyloidosis, and obstructive neuropathy. There we may get large kidneys, normal to large kidneys. Then we can go for renal Doppler and nuclear studies, CT MRI for renal artery stenosis and renal masses, voiding cystourethrogram to rule out any vesiculateral reflux. Coming to the complication of the CKD, it is a multi-system disorder. Most common system involved is cardiovascular, and the CVD is the mortality marker of mortality in case of CKD. CKD patient dies with complication of CVD, not from CKD. So most important is cardiovascular. Among cardiovascular, we encounter hypertension, coronary artery disease, heart failure, atrial fibrillation, pericarditis. Uremic pericarditis is absolute indication of dialysis. I will tell later on. Metabolic bone disease, MBD. 2 types, high turnover state and low turnover state. Among high turnover state, we found osteitis fibrosa cystica. पहले इसको रीनल ऑस्टियोडिस्ट्रोफी बोलते थे, आजकल ये टर्म ऑब्सोलीट हो गया है. लो टर्नओवर स्टेट, ए डायनामिक बोन डिजीज एंड ऑस्टियोमेलेसिया. Hematological anemia, I told, but the causes are multifactorial. The causes are relative deficiency of erythropoietin hormone, decreased RBC survival, bleeding diathesis, iron deficiency, hyperparathyroidism secondary or tertiary, vitamin B12 or folate deficiency, associated chronic inflammation, and coagulopathy and platelet dysfunction is also there, which leads to bleeding diathesis and another cause of anemia. Hyperkalemia and acid base disorder due to high potassium diet, due to reduced excretion from the kidneys, and certain drugs like AC inhibitors, ARBs, mineralocorticoid receptor antagonist, potassium sparing diuretics. So these drugs need to be judicially used or stopped in advanced cases of CKD. Neurological complications are there also, lethargy, seizure, coma, endocrine disturbances such as hypothyroidism, decreased libido, disturbed ovulation. Coming to the management portion, first what we can do, CKD is irreversible. Once labeled CKD, it cannot be reversed. But we can reverse some processes which can lead to CKD. We can, to some extent, halt the progression of the disease by these measures: dietary management, protein restriction, salt restriction, and potassium-free diet. Slow progression is achieved by tight control of blood pressure and tight control of blood glucose. And the agents recommended are ACEI or ARBs, and recently SGLT2 inhibitors have been added to this armamentarium. Avoid nephrotoxic drugs such as NSAID, aminoglycoside, radio contrast. CT MRI कराने में ध्यान देना होगा, या IVP कराने में creatinine कितना है. Aminoglycoside, amphotericin B, and tacrolimus, cyclosporin, we don't use physicians, but nephrologists use. Weight loss, exercise as tolerated, 30 minutes per day, at least 5 days in a week. And the salt restriction is less than 2 gram of sodium और लेस देन 5 ग्राम ऑफ सोडियम क्लोराइड. एक छोटी चम्मच नमक 24 आवर में रिकमेंडेड है. अबाउट प्रोटीन, द रिकमेंडेड डोज ऑफ प्रोटीन इन CKD पेशेंट इज यूजुअल 0.8 gram per kg per day. It may be increased up to 1.2 gram per kg per day in hemodialysis patient. Even it may be increased to 1.3 gram per kg per day in peritoneal dialysis patients. So don't restrict too much protein. Indian population is already protein deficient, so we do not advise strict protein adherence, abstinence. Protein should be modest. And hyperkalemia, to avoid the many things which contain potassium, like leafy vegetables, spinach, potatoes, citrus fruits, juicy fruits, etc. Now, what are the pharmacological therapy recommended? We have to target blood pressure. For that, we have some drugs, AC inhibitor, ARB. When to give? When CKD is documented without albuminuria, your target blood pressure should be less than 140/90. But if there is albuminuria in the range of 30 to 300 milligram per 24 hour, your target should be a little lower, less than 130/80. But if CKD is having heavy proteinuria, heavy means more than 300 milligram of albuminuria or more than 500 milligram of proteinuria per 24 hours, that is heavy proteinuria, then its target is still lower, that is 125/75. This is the target of blood pressure control. SGLT2 inhibitors should be used in CKD up to a GFR cutoff level more than 20 ml per minute per 1.73 meter square. And mineralocorticoid receptor antagonist also to be used up to the GFR range more than 25 ml per minute. Normal serum potassium concentration and albuminuria more than 30 milligram per gram. Hyperkalemia management, we all know insulin glucose solution in the wards, calcium gluconate 10 ml 10% over 5 to 10 minutes, loop diuretics, potassium binding regimens, and inhaled beta 2 agonist salbutamol. Now coming to anemia in CKD, which is multifactorial, to start EPO one should ensure that iron stores are adequate, because EPO will not work when there is iron deficiency. So it has been recommended to administer erythropoietin to patients with CKD who have hemoglobin less than 10, provided the T-sat level is more than 20% and ferritin is more than 200 nanogram per ml. So iron studies should include serum ferritin also. Without serum ferritin, one cannot judge. And dosing of some common EPO are erythropoietin alpha, which is common, 50 to 100 units per kg per week subcutaneous. Darbepoetin alpha is 0.45 microgram per kg once weekly, or 0.75 microgram per kg once every 2 weeks on dialysis patients, and 0.45 microgram per kg once every 2 to 4 weeks on non-dialysis patients. Other indication of EPO is anemia after chemotherapy and myelodysplastic syndromes. Contraindication are MI, stroke, any thrombosis, heart failure, uncontrolled hypertension and seizure. There is abnormality of calcium, phosphorus, parathyroid hormone, and abnormalities of bone turnover leading to CKD MBD. Management should treat hyperphosphatemia. Low phosphate diet target should be less than 4.5 milligram per DL. Dietary phosphate inhibition restriction diet up to the level of 0.8 to 1 gram phosphate per day. Foods like eggs, milk, dairy product, nuts, beans, meats should be restricted. There are two types of calcium phosphate binders: calcium based, non-calcium based. Calcium based, calcium acetate is the commonest used. Calcium carbonate can also be used. Among non-calcium containing binders are cevilamar and lanthanum. Maintain normocalcemia around 9.5 milligram per DL. Treat vitamin T deficiency, which is associated feature of CKD. If serum uric acid is more than 9 milligram per DL, it treat with these agents: allopurinol, febuxostat. Lipid lowering therapy to start above 50 years with eGFR less than 60 ml per minute in patient not on the current dialysis or kidney transplant recipient. We recommend treatment with a statin or ezetimibe combination. 1 minute. Recommendation on ACE. Start with ACE or ARB for people with high BP, CKD and severely increased albuminuria, and we can switch over ACE versus ARB, but never combine in to achieve more proteinuria, which it can dangerous hyperkalemia. Renal replacement therapy indications. Absolute indication of dialysis is neurological signs: uremic pericarditis, anorexia, nausea, recurrent vomiting, not controlled drugs, medically resistant acid base or electrolyte imbalance, intractable pruritus, refractory volume overload. Two types of modality: hemodialysis, peritoneal dialysis. Hemodialysis two types: center, at home. CAPD and CCPD are two modality of peritoneal dialysis. Then there are certain complications of hemodialysis: hypotension, muscle cramp. Peritoneal dialysis, there is peritonitis, infections, hypoproteinemia, hypoglycemia, weight gain, etc. Prognosis is bad. And take home message is CKD is a major public health burden which is an irreversible process. And the leading etiologies are diabetes, hypertension, glomerulonephritis, ADPKD. Up to stage 4 of CKD, patients are asymptomatic. In the later stage of CKD, anemia, fatigue, decreased appetite and other features of anemia develops. Bilateral contracted kidney is found in advanced stage of CKD. Modifier risk factors to be taken care of: lifestyle modification, dietary restrictions, avoidance of nephrotoxic drugs, target of blood pressure and blood glucose level, and pharmacological agents such as SGLT2 inhibitors, SAI, ARBs can retard the progression of CKD. Treat the various complications of CKD. Timely referral to nephrologist for creation of dialysis access and subsequent preparation for RRT. डायलिसिस शुड बी यूज्ड एज द ब्रिज टू रीनल ट्रांसप्लांट. जो ट्रांसप्लांट नहीं करा सकते उनमें डायलिसिस देने का कोई मतलब नहीं है. It is a bridging therapy. Remember, renal transplantation is the most definitive treatment. Thank you very much.
Thank you, sir. Chairpersons.
Very thanks to Dr. Jyoti Prakash for very learned speech. Now I will like to ask one question.
Sir,
In the remote area, if we are in a remote area and up to which level of creatinine we can use SGL2 inhibitor, because we are using very much SGL2 inhibitor.
GFR, eGFR more than 20 ml you can use,
Yeah.
safely use.
With creatinine, any relation?
2.53
2.5.
up to 2.5.
Thank you.
Any question from audience? Autosomal dominant polycystic kidney disease, sir. ADPKD.
Thank you so much. With that, since we have our next speaker also ready, can I request the chairpersons?
Yes.
So time थोड़ा सा कम है.
Yes, yes. 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 बिल्कुल बिल्कुल यूज करना चाहिए. SE inhibitors, ARBs. No, no, no. They don't have a so proven role. Na? N-cysteine has role in case of patient is going for radiographic dye studies or contrast nephropathy. Then it has some use. But in general case, you cannot write every patient N-cysteine. No role.
Well, I'll just have to say one thing. We can have this debate over a cup of coffee because
BP controlled, sugar controlled, then think of primary renal disease, primary glomerular disease, kidney biopsy is to be done.
all right. With that, sorry to interrupt, sir. Apologies, but with respect to the next speaker,
Thank you.
so much, sir. Yes.
I request Dr. A.K. Gupta.
Requesting Dr. A.K. Gupta, sir, to please join us on the stage.
Dr. A.K. Gupta, sir, from Agra, a member of governing body, please.
Dr. B.B. Thakur sir, Dr. D.P. Singh, Dr. Sharma. Long back when I was a student, I used to listen from Dr. B.B. Thakur when we were residents at Agra Medical College. And then several times I have listened to him. And today it is privilege that at his place, even after my retirement, I am very happy to see that Dr. B.B. Singh told me that Dr. Thakur would be coming. So the topic given by Dr. D.P. Singh to me is the pyrexia of unknown origin and what are some hidden facts. So let us see, everybody knows, all of us treat at one or the other time, several pyrexial patients we treat. So let us see what are some hidden facts. These are the common causes all of us are treating, ranging from tonsillitis, typhoid, urinary infection, liver abscess, tuberculosis, pneumonia, and malaria. And these are some uncommon causes, but they are found: infected endocarditis, Legionella, brucellosis, scrub, and cat scratch. There are some of the uncommon infections rather. In young age, pediatric and adolescent, the one which I like to mention is a tonsillitis. Recurrent fever lasting for few days or long standing. I only had yesterday a girl about 18 years having fever for last 3 months. कि 15-20 दिन बुखार आता है साहब, दवा से थोड़ा ठीक हो जाता है, फिर हो गया, फिर टाइफाइड हो गया, फिर हो गया. And she had a tonsils over there. So recurrent tonsillitis, does not cause pain in throat many times, and therefore the throat examination is ignored. And therefore in young patients, one important examination, even if the patient does not complain of pain in throat, the throat must be examined for tonsillitis. Common bacteria is staph and clarithromycin is the answer for that. Children and young, pyrexia, long standing with mild headache for weeks. Tubercular meningitis is an important cause. And many times when you get it done, the CT head is advised, but it may not be rewarding unless the hydrocephalus or tuberculoma is there. And therefore, if you are clinically suspecting, the lumbar puncture should be done to rule out tubercular meningitis. Typhoid, a very common disease, known as Miyadi Bukhar or Moti Jhara. Now one word about this, some of the postgraduates are also here, that this Moti Jhara word is the high grade fever lasting for few days cause the hypertrophy of the sebaceous glands, which is a Pseudomina reaction. And because once upon the time, the typhoid was the commonest cause of long-standing fever, and therefore the typhoid was given the name of Moti Jhara. Any long-standing high-grade fever will give rise to this Pseudomina reaction. Therefore, rash, the sebaceous hypertrophy, जो छोटे सफ़ेद दाने हैं, the villagers many times come with the history that this is Moti Jhara because the dana, they only signify a high-grade fever lasting for a few days, and that is not synonym with this. Once upon the time, since the typhoid was the commonest cause of long-standing fever, and therefore it has been given the name the typhoid or Moti Jhara. The gold standard is of course the blood culture, is not available at all the centers. A word I will like to mention about the Vidal test, its interpretation and some of the fallacies. It detects antibodies against O and H. The cutoff predictive value by NTO is 1 in 80. In general, the herd immunity is taken as 120, and therefore a four-fold rise, 1 into 20 into 4, that is the 120, then this test is considered as positive. Agglutinin appears by the end of first week, it rises till third and fourth week and later declines. The important thing to remember, I will like to mention that NTO becomes negative after 6 to 8 weeks. Even after the fever subsides, the NTO will not come to the negative side, and NTH remain positive for about 1 year. Normally, Vidal test is done by tube agglutination method, but in the interior places, they do it by plate method, which is highly erroneous, gives a wrong results, and people from the smaller places still they bring the report mentioning कि साहब ये गांव में कराया है टेस्ट और ये टाइफाइड का पॉजिटिव टेस्ट है, and therefore it should be taken as a pinch of salt, and all the patient we are mentioning should not be taken as typhoid. Since in Vidal H remains positive for 1 year and O positive for 6 to 8 weeks, and many times we have seen that the lab technicians or pharmacists, they bring the report कि साहब ये बुखार तो ठीक हो गया, ये विडाल अभी मेरा बुखार पूरा गया नहीं है, या तो थोड़ा बुखार आ रहा है किसी और वजह से, और या विडाल क्योंकि पॉजिटिव चल रहा है तो साहब टाइफाइड तो मेरा ठीक ही नहीं हुआ. Clinically, the typhoid will become all right in 3 to 4 weeks. Therefore, if fever lasts for more than 1 month, then it is not typhoid. And patient brings the positive report saying typhoid is not subsiding while the cause in the patient is something else. This must be remembered because this is paramedical workers, the pharmacists, the medical shop persons, they create the confusion in the mind of the patient by showing the report again and again that आपका विडाल तो अभी positive है और typhoid नहीं गया है. Vidal test is high false positive results also. And you see here that by the blood culture specificity is 100, the Vidal test only the 86% specificity is there. Typhidose test detects IgM and IgG separately. Again in this test, the IgM remains positive for 3 months and IgG may remain positive for 6 months even after the cure of the disease. And therefore, even the typhidot, if the patient becomes all right, a negative typhidot, you should not expect that it will become negative. And therefore, the Vidal we see here becomes positive in 7 to 10 days, while the typhidot becomes positive early, and it takes 6 to 8 weeks become negative, while H takes 1 year. In typhidot also, the negativity may take 3 to 6 months, and therefore a remaining positive Vidal does not mean that the typhoid has not subsided. Either the patient is having something else or some else fever. Therefore, these tests should not be done for follow-up, as they remain positive for long period and they create confusion that typhoid has recurred again and again or it has not been cured. Malaria, the gold standard everybody knows is the blood film. Other tests are there. The important thing which I would like to mention is if the test is positive, then it is malaria. If the test is negative, it can still be malaria. We know that long back, one of the industrialists in America died of malaria when on postmortem because the MP was negative and therefore he was never given the anti-malarial treatment. Blood smears thick and thin will solve the problem. If the patient's of symptoms comes with this, with a negative test, then don't hesitate to start the anti-malarial treatment you can give clinically. In young males, the liver abscess may present commonly with fever. If the patient does not complain of pain in abdomen, ultrasound is not advised. So in all PU cases, the ultrasound is one important thing. And the only one important thing which I like to mention, sometimes a small liver abscess may be missed or misdiagnosed by a new ultrasonologist. Amoebic liver abscess is a standard treatment, nothing to mention. In pyogenic liver abscess, that is the treatment which should be given for 14 days. Urinary tract infection is another important thing, and pus cells in females, they are normal 3 to 5, and in males 1 to 2, they are considered to be normal. Increase in pus cell count along with symptoms can be helpful in assessing UTI. But the pus cells and epithelial cells in microscopes seems to appear alike with the difference of a dot in between. And therefore, a close observation must be done to differentiate these cells to provide a better result. Otherwise, sometimes the pus cells are mentioned as epithelial cells and sometimes the epithelial cells are mentioned as pus cells. Urinary tract infection in young female, that is the commonest cause. They usually complain of burning, but sometimes the lower abdominal pain or in the upper thigh or back, and many times urinary symptoms are not present. So look carefully for urine, take the morning urine sample as that is concentrated and examine for pus cells and be alert for epithelial cells. Most common organisms is the E. coli and the different antibiotics are there to cure the disease. In females, after delivery fever is very common. Catheterization at the time of delivery or after seizure is one very important cause. Fever usually comes after a few days. So please get a urine examination done. Otherwise, all the things are being done and the lady is suffering from urinary tract infection. Male old age. Two combination, a diabetic with prostate is probably the commonest cause. Uncontrolled diabetes and retention of urine in bladder due to BPH cause fever. BPH symptoms may be or may not be there. Undiagnosed diabetes, previously the patient resists for sonographic examination saying that there is no history, but if in old age he might have developed mild diabetes, the sugar must be done. This is an example, an elderly male patient having associated poorly controlled diabetes, he now develops BPH, and this leads to urinary tract infection, and a long-standing fever is a cause in this gentleman. The patient will come with complaints of UTI, and treatment is started for UTI, but unless the diabetes is controlled, the UTI will not be cured, and do not forget to add the treatment for BPH also. Therefore, in an old UTI person, the diabetes must be excluded and should be taken care of, and the treatment for prostate must be added at the same time. Any infection with diabetes will not be okay until the diabetes is controlled. In India, the tuberculosis should never be forgotten. Any part of the body, the tuberculosis can be there, and the tuberculosis and diabetes, when they go together, and while treating diabetes, it is said that insulin heals the infection, any sepsis or tuberculosis, faster. So to begin with, you can give insulin for some time, and then the oral drugs can be given. Fever, weight loss and decreased appetite. Search for malignancy. Lungs, prostate and GIT. And therefore, if the cause is not being found anywhere, a CT chest and CT abdomen, and many times you will get the diagnosis. 3 uncommon causes of PUO: hyperthyroidism, a viral thyroiditis or Graves' disease, a rheumatoid arthritis or leukemia. They also many times come with a mild degree of fever of a long duration. 3 rare but important causes are if the TLC is lower normal or the ratio is reversed. The hypoplastic or aplastic anemia is another cause which the patient can present with pyrexia of unknown origin. If the count is high, you do a toxic granules. If the infection, the toxic granules will be positive, and the procalcitonin will be positive. If the toxic granules are not present and the mature TLC is seen, this is another cause creating confusion. Patient getting steroid for any of the disease, skin allergies, bronchial asthma, rheumatoid arthritis, the count is high, but the toxic granules will not be present in total leukocyte count, and procalcitonin will be negative, and therefore a word of caution that while the TLC is raised, please look for the toxic granules to decide whether this is a steroid being treated with the patient or the patient is harboring some septic focus. TLC showing occasional abnormal cell, all of us know this is leukemoid or leukemia, and go for bone marrow examination. If cause is not found, investigate thoroughly as we have discussed. If facility for investigation does not exist, the empirical treatment is sometimes started. You can cover the typhoid with the amoxicillin, and some of the rare infections of Legionella scrub, you can give it doxycycline trial for 10 days to 6 weeks given for Legionella. Malaria, doxycycline also works with the antimalarial, and for urinary tract infection, aminoglycoside. And therefore, better to do the investigation thoroughly, but if no cause is found, these are the common things, and if the person is sitting at a remote area where the investigation facility does not exist, the trial can be given to treat the patient. Thank you very much. Usually the long lasting, the pyrexia unknown origin usually goes for 2 to 3 weeks, dengue usually 5 to 7 days, but this is just one cause that should
Yes, Dr. Gupta, you have wonderfully taken us through A, B, C, D to Z. I only like to add one thing, which I have found in my practice. The primary care physicians forget to get HIV test done.
Yes.
And in many of the cases, that only test was done and it came out to be HIV and AIDS. Number two, if there is any pain in the right lower abdomen or upper abdomen and history of TODI, it is amoebic liver abscess, nothing else.
Yeah,
So
therefore I
you can
mentioned.
even clinically diagnose.
Yeah.
And you have rightly covered almost all. So I have nothing to say. I have learnt a lot. And thank you for reminding me of the past, of Dr. Wahal, etc.
Dr. Vahel, Dr. M.C. Gupta, Dr. M.P. Mehrotra, and then I have learned from you also.
And I would like to thank Dr. A.K. Gupta sir for finishing it 30 seconds before time as well. Now can I request all the three speakers and the chairpersons to please join us just outside the door. There is a felicitation ceremony. We would like to give you the mementos and also thank you. Requesting all the three speakers again, Dr. Partha, Dr. Jyoti, Dr. A.K. Gupta to please join us outside. And as we have the conversations, can I request the chairpersons for the next session to please join us? I request Dr. Partha Karmakar sir to please join us as a chairperson, Dr. Satish Chandra, Dr. Navneet, Dr. Vijay Krishna Singh, Dr. Obed Ali, and Dr. Ajay Kumar Singh to join us as a chairperson. To save time, can I also request our first speaker, the dynamic Dr. R.K. Das sir, to please join us on the stage. In the meanwhile, he can check his presentation, maybe click a picture for his Instagram or Facebook. Chairpersons, please. First slide, Ajit. Jaldi, jaldi, next slide dalte ja yaar. Yes, we've got one chairperson, and I think he akela hi kafi hai. He is the Rajnikant, I would say then. Yes. So, with the permissions of the chairperson, can the chairperson give a thumbs up so we can have a party in the evening also? Yes. Please, Dr. R.K. Das, you can get started. Dr. Abhilesh Kumar, could you please be the chairperson? Yes.
So, good evening everyone. I will welcome Dr. R.K. Das for the session, and now we can start the session for the talk.
Thank you, sir. Good evening, everybody. My special regard to a stalwart of medicine, Professor B.B. Thakur, sir. Now, this article, that is ABG Guided Management of Acute Exacerbation of COPD, a prospective randomized controlled trial, is actually a original research of my passed out PG, Dr. Pramay Prashant, which was directly directed and supervised by me. Have got chance to present you this topic, which is very useful, I think. So, before I start with what is known, what is not known, and what the research is going to give to the medical fraternity or add to the medical fraternity, I will like to say in the introduction that there are three words. The one is COPD, the another one is acute exacerbation of COPD, and the third word is ABG. These words are very old entity in the medical science, out of which COPD, the evaluation, that is your quantitative evaluation of COPD is established. That is obstruction by a spirometer, your dyspnea by MMCT, and the another factors, other complaints and the factor by multi-directional questionnaire, that is through CAT. So it is established. Now acute exacerbation of COPD, in which the main complaint is dyspnea, and you cannot do the spirometry to evaluate it. So the dyspnea, it is the problem of the respiratory system, it is problem of the heart, it is problem of the anemia, it is problem of the metabolic acidosis. So this dyspnea you will have to define why it is, and if you will take time to investigate all the things, you will have no proper medicine to start in the beginning. So it is not well defined. Even the definition which has been given is not perfect because it is clinical, that is symptomatic, it is depending upon the pulse, respiratory rate, temperature, and that of SpO2. So that is variable also, the latest one in the gold 2044 guideline also. They are consistent over these symptoms. So quantitatively, you cannot evaluate what is the value. And the third one is ABG. ABG is important component of evaluation of acute of the patient who present with the complaint of breathlessness, cough and sputum, that is exaggeration of that, so acute exacerbation of COPD. But, and not only this, in my one work, ABG Gold Standard in Emergency Department, which was published in Journal of Medical Science and Clinical Research in 2019, it was found that ABG is the important investigation which can help in diagnosis of the acute exacerbation of the COPD, which can define the management plan of the acute exacerbation of COPD, and it can be used as grading of severity of acute exacerbation of COPD. But in the 2024 guideline of GOLD, which was published on 14th November 2013, even that guideline does not say, they say that ABG should be done in moderate to severe acute exacerbation of COPD. There are volume of literature, journals, and chapters in the book which say you about the COPD, but there is one few lines for that of acute exacerbation of COPD. Although the mortality has decreased due to widespread use of BiPAP machine, particularly after the COVID infection. With this, we start what is known. So, acute exacerbation of COPD in the medical science is just like that. It has grown from infant to children, and the children is looking forward so that it will be grown very shortly. So this picture predicts like that. Even the definition of the COPD has been changed by GOLD 24, which was published in 14th November. They say that it is a persistent progressive airflow obstruction due to airway alveolar abnormalities. This is the change from 2023. And here it is written that it is the fourth leading cause, but the guideline, the update given by GOLD 2014-24, they say that it is the third leading cause of that, and I think which was evaluated at 2019, and I think it is due to COVID infection. They have not written like this. You are well aware of this. The severity of COPD can be decided by this spirometric chart, where the ratio is less than 0.7 and the forced expiratory volume varying from 80 to 30, more than 81, 80 to less than 80 to 52, 30 to less than 53, and less than 34. That is mild, moderate, severe, and very severe. And now they have given it grading, that is grade 1, grade 2, grade 3, and grade 4. Now, this definition of exacerbation of COPD. In this condition, they have told that the symptom, which is the dyspnea, which is the cough, which is the sputum, which has increased naturally, and they had given less than 14 days, and it should be associated with tachycardia and tachypnea, but 2024 guideline, and they have classified they have accepted the Rome classification as mild, moderate, severe. But in 2024, Gold says that it is the sign of the patient which decides the severity of the patient. You can think what is the status of this acute exacerbation of COPD till date. Now, on the basis of this symptom, these parameters, that is pulse, respiratory rate, SpO2, they have graded mild, moderate, and severe. I told you this is not quantitative, this is qualitative, it is variable. In my one research, I had found that the 33% patient who is diagnosed as acute exacerbation of COPD, they have established COPD. And the 30% of the cases who had diagnosed as a established COPD has acute exacerbation of COPD, and that is also published. Now, in this chapter, we have to say that there is more problem. Patients' exacerbation are generally not able to perform spirometry naturally. PFT has not been demonstrated to be helpful in diagnosis and management of exacerbation. You all know, Indian Journal of Clinical Medicine study states that there are no confirmatory investigations which can appropriately diagnose cases of exacerbation. Now, the answer of all these things is simple ABG. ABG is the answer which should be done in all suspected cases. And previous and present guidelines suggest ABG on only advanced phases. I told you. Analyzed report of ABG has power of diagnosis. It had to say the power of prognosis. You can formulate the severity, grading of severity. You can have this management protocol to be decided if you go through that. And for this purpose, the ABG has been simplified. It is not to go too much. So what is not known? Grading of severity of AE-COPD, that is quantitative grading, is not known. And definite guideline for inpatient treatment has also not been given because they are variable, they are clinical, they are not quantitative. So everybody has different types of management of the acute exacerbation of COPD. Now we have proposed the grading of severity. If a patient have PaCO2 more than 49 and bicarbonate more than 26, if the patient have pH 7.36 to 32, it is known as mild. That is 32 to 7.20 moderate, and less than 7.20 is the severe one. Now the treatment protocol which I have proposed, in mild case it should be pharmacological. In moderate cases, pharmacological with non-invasive ventilation, that is BiPAP machine. And in severe cases, if not improving, if there is sustainedly hypoxemia, the patient can be kept over ventilation, invasive ventilation. Now, on my study, I have promoted the definition of AE-COPD. That is, should be episodic acute worsening of respiratory symptom along with ABG finding of acute on chronic respiratory acidosis suggested by raised PaCO2, raised bicarbonate, and low pH with or without hypoxemia. Now the material and method you all are knowing. The sample size is the important one, which was derived to be 120, 60 were kept on the case group and 60 were on the control group. Case group was by ABG monitoring and control group by traditional method of treatment. Inclusion criteria was more than 40 years of age, having breathlessness, cough and fever symptom, all these things. Less than 40 years is not considered, comorbidity were not considered. ABG analysis was done. Now, this arterial blood is taken before a start of the treatment of the patient. And the analysis was done. The analysis was done by R.K. Das Indian 2017 method of ABG interpretation, which was presented in Epicon 2018 and have got a chapter in Medicine Update 2018 also. These have the headings: accuracy of ABG, gas analysis, electrolyte analysis, acid-base analysis, and conclusion. Here, you have not to go in full detail of that. You have two important things. You have to do the gas analysis and you have to do the acid-base analysis. Two important things are there. In gas analysis, you have to decide type of respiratory failure, you have to decide severity of hypoxemia, you have to decide the cause of hypoxemia, because you know the hypoxemia, the cause of hypoxemia have different one which can be decided by this ABG. That is low FiO2, that is hypoventilation, ventilation perfusion mismatch, then shunt, and the lastly is diffusion defect, and P/F value is important also. So type 1 respiratory failure, if PaO2 is less than equal to 60, type 2 respiratory failure for PaCO2 more than 49. This PaO2 alveolar oxygen and difference is for deciding the cause. The Pa minus AO2 in normal population can be calculated by age by 4 plus 4. It should be less than 15, but growing age it can go up to the 30 minutes. Hypoxemia is graded mild 60 to 80, moderate 40 to 60, and severe is if the PaO2 value is less than 40. Now this is the chart which is showing you to decide the cause of hypoxemia. If the patient's carbon dioxide is increased and the PaO2 is not increased, in that condition, if the carbon dioxide increased, if it is yes, it is hypoventilation. If Pa minus AO2 is also increased, means this hypoventilation is associated with that of this hypoventilation is associated with your two condition. One is ventilation perfusion mismatch, and second one the shunt. And shunt is the condition which is difficult to be treated. Acid-base analysis, you have not to go much in detail. Simply, if you suspect the patient AECOPD, you do the ABG and find the PaCO2 value. If it is more than 49, bicarbonate value more than 26, and pH is less than 7.6, you can label it that a case of acute exacerbation of COPD. Actually, this is a chart which is showing you the treatment planning for mild, moderate, and severe. This is indication of ventilator, that is invasive ventilation, you are well knowing, and the outcome will be calculated as a primary outcome and secondary outcome. Primary outcome as a discharge, death, and referral, and secondary outcome duration of hospital stay. The baseline demography says that there is no difference in age and sex, significantly no difference in both the groups. The baseline clinical characteristics says that there is no difference in shortness of breath, that is 60 and 60 in both the group. The baseline characteristic of vital says that there is no significant difference from the p-value you can say. And severity of acute exacerbation of COPD, you can see that mild cases in group 1 was 15, that is 25%. Another group which was 45%. Moderate to severe was 75% in the ABG group and 55% in the another group. The 12-hour treatment, it was found that the vitals decreases, but it is not significantly decreases. After 24 hours, the vitals say they have significantly decreases, and this hospital stay is less than 5 and 5 to 10 in the cases of your ABG managed group, but the hospital stay is more than 10 in the 10 days in the cases of your traditional management group. Mortality parameters, only 2 patients died in the ABG managed group, while 7 patients died in the traditional method. The survival was 81.7% in the cases of traditional management,
and it was 96.7%. Here I will like to say that worldwide marker is also 83% survival with the traditional method of management. So it matches with that. So the primary outcome was survival, 96% with ABG and 81.7% from that of traditional method. Death was significantly low in the cases of ABG group and the referral was low. So analyzed report of ABG is better for grading of severity of AECOPD. ABG patient with severe persistent hypoxemia mortality is 100%. Mortality is significantly low in ABG guided group. Hospital stay is less in the ABG guided group. ABD guided management do not require referral. Success rate of ABG guided management is 96.7. The research has power of generalizability. And at the last, I will say that physicians should have multi-center trial to establish the grading of severity and thus decide definite management protocol. And I say the gold expert also to look it and do in this line so that concrete decision can become. Thank you very much.
Thank you, sir, for your nice presentation. The matter which glitters is not always gold. The history is very important because I have seen a case few days back. The lung picture shows, the chest x-ray shows the upper zone and mid zone, both lung field was floppy, and the patient responded with hydrocortisone in 2 days. I have diagnosed that case, hypersensitivity pneumonitis. That means that everything that is the SOV on exertion is not COPD. And AVG is the only, I think, that is important in case of only acute exacerbation. That is not the deciding factor in case of the chronic COPD cases. Thank you, sir.
We were running short of time. If you could take it offline, that would be really appreciative. Only vast.
Sir,
Yes,
we are running short of time, so the questions.
More than 26. Sir, when you keep the patient on ventilator, you have to manage the patient. So the ventilatory setting is important in that condition. If you will decrease the rate of respiration, naturally the carbon dioxide, the bicarbonate will go up, carbon dioxide will go up, carbon dioxide will go up. If you will keep the patient on the low respiratory rate, less respiratory rate, the carbon dioxide will go up. And if you will keep, if it is going up, in that condition, the patient's pH immediately is not going to be corrected because kidney takes time to be corrected 3 to 7 days. So it is the carbon dioxide and it is the oxygen which you have to maintain, because in the cases of this acute exacerbation of COPD, persistently severe hypoxemia, which is due to shunt, is also a severe condition, not only pH. That factor is also important. And that persistently decreased hypoxemia is generally not corrected easily with that ventilator also.
Sir, with respect to
so sir, in that condition, the problem is the monitoring one. And the relation with the bicarbonate you will not get urgently. It is the metabolic acidosis in which you will get immediate effect of the rate of respiration and the carbon dioxide wash out. But in the cases of carbon dioxide excess, if you have decreased it, you cannot decrease the bicarbonate immediately because it takes 3 to 7 days time.
All right. Thank you so much. With that, I request
The
our next speaker,
yes,
Dr.
sir.
Vinod
Your actual thing
Chaudhary,
is
sir.
the PaO2 should be more than 52 millimeter of Hg in this condition. This is the principle you have to maintain,
Can
that
we-
PaO2 should be more than 52.
Yes, can we have a big round of applause for Dr. R.K. Das, and we have Dr. Professor B.K. Chaudhary sir, Binod Chaudhary sir. I'm just taking the opportunity. Yes, over to the chairpersons.
I will invite Dr. Binod Kumar Chaudhary, Professor sir. He is a professor in the Department of Medicine, and his topic is basics of HRCT and respiratory disease. Thank you.
Respected dignitaries on the dais, off the dais, ladies and gentlemen, respiratory diseases have become very common, very rampant these days globally. And the diagnosis is a big issue. That too, the time has come when we do least invasive investigations. Initially, we used to give the diagnosis, we used to confirm the diagnosis by doing biopsy, lung biopsy, and other maneuvers, bronchoscopy examination, BAL examination. Now, we should know the pattern of the HRCT, the basics of the HRCT, which is being held by AI, artificial intelligence. So the future is of the future generation, the postgraduates sitting here, they are going to get a lot of cases in the future. They should know the basics. How do you give the diagnosis? How do you think about it? So my first slide. Understanding the anatomy of the secondary pulmonary lobule is very important. First thing, there are four things. You recognize how the SPL is affected by the disease. What is the dominant pattern you take? I think most of us, initially we never knew how to catch hold of the HRCT and from which angle you used to diagnose. There is a pattern. You have to follow it. And identify the dominant pattern, characterize the distribution. It is upper on the upper lobe or the lower on the or periphery on the center, and identify concomitant findings. So this is the SPL, secondary pulmonary lobule. Each lobe is having so many secondary pulmonary lobules, 30 to 50 SPL in each lung. That is most important. One of my UG students asked me, sir, why do you teach about SPL? Why don't you teach about PPL, primary pulmonary lobule? I said, no, it's not visible on the X-rays or the HRCT. That is why whatever we do talk about SPL, that is secondary pulmonary lobule. It's a very polyhedral structure. This is the SPL. Two SPL are there, and setting of the pleura, interlobular septa. Its size is 2.5 centimeters, supplied by 3 to 5 terminal bronchioles, contain 5 to 15 pulmonary acini. This is another structure. So in the center, there is a centrilobular artery running along the centrilobular bronchus. This is the blue structure. You see the blue in the center. This is the core. This is the centrilobular structure, and it consists of the accompanying pulmonary artery and the lymphatics. This is blue, and the artery running is blue because it is carrying the deoxygenated blood. So, the disease affecting this part is aspiration, centrilobular emphysema, hypersensibility pneumonitis, infection, inhalation disease, and respiratory bronchiolitis. The peripheral structure, the yellow one. On the other side, we were just discussing about the one. This yellow one. This yellow one is interlobular septa consisting of the artery, of the vein, pulmonary vein, which carries the oxygenated blood. That is why it is red. What are the diseases affecting this part is pulmonary edema, sarcoidosis, lymphitis, carcinomatosis. This is very important. Now we have to know the patterns, the special patterns, and there are so many patterns, but four are very important. Lines. Whenever you take a HRCT, first thing you have to see the pattern, where you see the lines or you see the reticular opacities. Then again, it is of four types: interlobular, intralobular, smooth, and nodular. Another one is nodule. Nodule. That is the nodule on that side, consisting of three parts. Centrilobular is the center one, upper part is the random, and lower part is perilymphatic. Second pattern is areas of increased attenuation. Two part things, examples only: GGUs and consolidation. Areas of decreased attenuation, emphysema, cystic lung disease, bronchiectasis, honeycombing. So we have discussed about the 4 patterns. So the basic interpretation is dominant pattern, whether it is reticular, nodular, high attenuation, low attenuation, distribution in the secondary lobule, centrilobular, perilymphatic, random, distribution within lung, upper versus lower, central versus peripheral. So basic structure we have already discussed about it. The dominant pattern we have to know. Then now first example is reticular pattern. Reticular pattern, this is example of reticulations. You see the prominent SPL. Can you see this secondary pulmonary lobule? The prominent ones, the thickened, the intralobular septa, they, is it working?
Hello.
These are the different examples. The reticulopacities may be smooth or nodular. Now this is a case. This is a beautiful case example of septal thickening. These are the thickenings. Septations. Postgraduates? Following? These are the septations. Interlobular septation. They are thickened.
Check.
Why this one is clear? Only one lung is affected. What may be the diagnosis? Anyone? It might be a case. It might be a case of lymphangitic carcinomatosis. Next one. This is a beautiful sketch, smooth example of smooth thickening. Example, nodular thickening, irregular thickening. Smooth thickening can be because of pulmonary edema, pulmonary hemorrhage, lymphangitic carcinomatosis. Nodular may be lymphangitic carcinomatosis, sarcoidosis, amyloidosis. आवाज जा रहा है? And irregular thickening is an example of fibrosis. All right? This is an example, another focal septal thickening, in example of lymphangitic carcinomatosis. हो गया? टाइम मेरा लॉस हो रहा है. हो गया? This is an example of focal septal thickening. These are all. Postgraduates, you recognize the SPL, secondary pulmonary lobule. You understand? If you know you recognize the secondary pulmonary lobule, you know the HRCT. If you don't know, you have to depend on the radiologist. And if you read it well, you are better than the radiologist. Another beautiful case. all small septal thickenings, with gravitational. This is a case of cardiogenic pulmonary edema. This is reversible. Now this is a case, 77-year-old male with a 3-year history of progressive dyspnea on exertion. What are the findings? House? What are the findings? Anyone? No, I am asking the findings. You see these things? Yep. These are the honeycombing. Lateral. Anything else? The first thing, but before telling honeycomb, you should say septal thickening. Septal thickening. Honeycombing is low attenuation. So that is another finding. Septal thickening, low attenuation. This is honeycombing. This is in the beginning. Initiation. This is a full-blown picture of IPF. Interstitial pulmonary fibrosis. So what you have to take home message for all of you is, what is the most likely diagnosis? IPF. What are the different notable radiographic findings you find here? There are 5 findings. You have to remember, peripheral reticulations is very strong. Peripheral reticulations. Peripheral reticulation, honeycombing, ground glass is very low. If there is ground glass, it may be NSIP or it may be chronic hypersensitivity pneumonitis. Reticulations, honeycombing, less ground glass, IPF. More ground glass, NSIP or chronic HP. That is very important. So these are the 5 findings: peripheral reticulations, honeycomb cysts, traction bronchiectasis, lower lobe predominance, minimal lobe GGOs. So always remember these findings for giving the radiological diagnosis of IPF. Case 2. A 42-year-old male with 1-year history of progressive dyspnea with mild exertion and chronic dry cough. This is NSIP. How do you say it is NSIP? Anybody? Non-specific. Non-specific is non-specific. When you don't get any diagnosis, you give the diagnosis of NSIP. But there is a but. This one. Pleural sparing. Pleural sparing is very important. You differentiate from IPF by pleural, subpleural sparing. This is another very important thing. This is a heterogeneous lung. Heterogeneous. There are 3 types of densities here. 3 densities. Normal density, low attenuation, high attenuation. We call it head cheese sign. Head cheese sign is a characteristic of chronic hypersensitivity pneumonitis. This is another example of hypersensitivity pneumonitis. Always remember this diagram for whole of your life. Basal distribution, remember IPF, CTD, ILD, drugs, asbestosis. Upper zone, middle zone, sarcoidosis, chronic hypersensitivity pneumonitis. Always remember this figure for whole of your life. Next generation is going to face, you'll be flooded with these types of findings. AI will help you in giving the diagnosis, because there are more than 200 types of ILDs prevailing in the society. There are different types of 3 types of cellular fibrosing mixed. Non-specific is non-specific because in UIP pattern 22% in this, hypersensitivity pneumonitis 20%. This is OP is organizing pneumonia 14%, others 20%. So NSIP itself doesn't have. Only positive point with NSIP is it may be secondary to some CTD. All CTD gives rise to NSIP except rheumatoid arthritis. Rheumatoid arthritis gives rise to UIP pattern. Always remember this line. Now, first we discussed about the linear, the lines, the reticular pattern. So there are 4 patterns, PGs: reticular, nodular, low attenuation, high attenuation. Now we are discussing the second one, nodular. The nodule, this is the nodule. 3 parts: the random, the centrilobular, the perilymphatic. These are the perilymphatic. These are very important. Subpleural, along the fissure, around the perilymphatic. This is very important to know because after showing so many slides, I wish nobody will miss the diagnosis of sarcoidosis in his life. I'm going to show all the slides. क्या हो गया? Line करा? Should I continue? उस पर तो आ गया. It's coming over there. Okay. The nodular pattern is very important. Centrilobular patterns are evenly spaced. Spare the outer 3.3 to 5 millimeter. This pattern suggests a dissemination endobronchial. The endobronchial tuberculosis, the non-TB mycobacteria and bacterial bronchonemia affects this one. Also found in RB and heavy smokers in hypersensitive pneumonitis. This is an unknown case. Anybody can give diagnosis of it? PGs, 100 rupees in arm. Sorry, this is not a class, but just to make it more interesting. Sorry? Done. 500 done. 500 done. मेरा PG नहीं ना है, वो बोल देगा. I'll discuss because all beautiful. I'll tell later on also. You see, ये क्या है ये क्या है, और ये क्या है? Subpleural nodules. Nodules along the fissure. Perilymphatic nodules. Nodes. Sarcoidosis. अभी और बताएंगे डिटेल में आज के आगे. ये this one unknown case too. Anybody? PMCH? This one? So this is an example of interstitial septal thickening. We will be discussing the cases one by one. Interstitial pulmonary edema. Lines outline lobules of characteristic size. Again you see the prominent. The SPL, the secondary pulmonary lobule are prominent. Nodules have got 3 perilymphatic distribution, random and centrilobular. Now this is a beautiful. Remember it for whole of your life. Perilymphatic nodules are affected. Nodules in relation to lymphatics. बताए थे अभी. Nodules. ये क्या है? What is it? These are subpleural nodules. This one, this one, this one, this one, this one. These are the nodules along the fissure. And these are along the perilymphatic. One more. Perilymphatic nodules. Subtle nodules. So what is the differential diagnosis here? Sarcoidosis is one. That is the commonest. Lymphangitic spread of tumor. Because lymphatics are passing through, that is why all the cancer metastasis spread through that. So that is important. Silicosis, core workers, pneumoconiosis, uncommon. Amyloidosis का हमेशा differential diagnosis रखना है. All PG, all cases में DD में. Always remember amyloidosis. So this is the case of sarcoidosis. Now we are discussing about, we discussed about the centrilobular nodules. These are the random nodules. These are the random nodules. Random, randomly, but evenly placed. Random. All over the lung. Random nodules. Random distribution relative to lung structure subpleural nodules. Occur in relation to central bronchial artery. This is a tree in bud. Have you ever done a tree in bud? Actually, it is a budding tree. Centrilobular. Come on, boys. Centrilobular. This is dilated, impacted centrilobular bronchioles. Clustered centrilobular nodules or rosettes.
क्योंकि मैं लैपटॉप लिया इसलिए
कहाँ मिलता है?
शौविक
Chatterjee?
मैंने देख लिया
Where do you find this? Tree in bud? Tree in bud, where do you find? What are the causes? This is a beautiful case of centrilobular emphysema. I'm showing the figure. The very important thing is, these are all cystic structures. Actually, they are not cysts. They are destroyed lung, destroyed centrilobular emphysema. But the characteristic is centrilobular artery is visible. Centrilobular artery is visible in the center. We call it centrilobular emphysema. And the most important diagnostic catch is imperceptible wall. The walls are imperceptible. Imperceptible. There is no wall. That is the difference from the lamp. Deepak, तुमने lamp पे present किया ना? Lamp. That is the difference with lamp. Centrilobular emphysema. Panlobular emphysema. This is a panlobular. Panlobular emphysema. This is normal lung. This is normal lung, this is abnormal. Is it possible in one patient? One normal, one abnormal lung. Their lung transplantation has been done in this case. Paraseptal, this is the commonest, and this is a beautiful finding. Paraseptal is a characteristic that affects the upper lobe. And the pneumothorax, which is a very important complication of paraseptal pneumothorax, this is the cause. Paraseptal emphysema. All right? Now we are discussing about lung cysts. They are air-filled lesions, localized, thin wall, well-cell crown, larger than 1 centimeter. So we do have a lot of different DDs. Honeycombing or emphysema, bullous emphysema, or cystic bronchiectasis, they are not cysts, they are differential diagnosis. So lung cysts are basically, we have 4 types of lung cysts we deal, we'll be discussing one by one. This is a very important thing. You might have heard a lot about traction bronchiectasis. This is the classical traction bronchiectasis. The bronchus is being tracked away. And these are the honeycombing. These both suggest fibrosis. Both are of sinister sign. Both are present, that means prognosis is poor. Beautiful case, another case, beautiful case. What are these? These are cysts. These are bronchiectatic changes. This is filled with mucus. Bronchiectasis. Pneumocystis xerovichii pneumonia. Bronchiectasis, air-filled levels, wall thickening, lower lobe predominance. This is a beautiful case. Anyone? What is it? This is a coronal sagittal section. What is it? Finger in globe. Yep. And then what is this? String of the grape sign. Grapes. These are all bronchiectasis. All findings of bronchiectasis. This is signet ring sign. Bronchus is larger than accompanying vessel. These are the types of bronchiectasis. Now let us come for the lamb cysts. So this is very important. Unless what the mind does not know, eyes do not see. If you don't know about it, you can't give the diagnosis. Lamb, you have to think of lamb. In a childbearing age female, lamb is a common possibility. All beautiful round shaped cysts, but intervening lung tissues are normal. Intervening lung tissues are undisturbed, unruffled. So this is lamb cysts. 1% cases tuberous sclerosis. Cysts round in shape, usually thin walled, intervening lung normal, diffuse distribution, pneumothorax only in women of childbearing age, 1 degree of 1% of patient with TS. LIP, lymphocytic interstitial pneumonia, is another cystic lung disease. You remember one fundamental simple bath, NSIP plus cyst is called LIP. That is, remember, LIP is nothing but NSIP plus cyst. Always think of LIP, you'll get the diagnosis. Case 3, a 45-year-old African American male with a 3-month history of cough, increasing dyspnea and intermittent fevers. Findings. Postgraduates? अभी बताए हैं. Very good. What is it? What is it? And what are these? So what is the DD, commonest DD? Sarcoidosis. That too stage 2. So what are the notable radiographic findings? Perilymphatic nodules, nodules along the fissures and pleural surfaces, extensive involvement of the axial interstitium, middle and upper lung zone, mediastinal and hilar lymphadenopathy. This is very important. SPL we taught in the beginning, the secondary pulmonary lobule. This is the secondary pulmonary lobule. So they are peribronchovascular nodules. These are the subpleural nodules. These are the interlobular septum nodules. So these all go in favor of sarcoidosis. So one message I wish to push to all of you, especially the postgraduates, never miss the diagnosis of sarcoidosis. Very underdiagnosed situation in this part of the country. It's very rampant, I tell you. Unless you don't know, you can't give the diagnosis. Now this is about the third thing, low attenuation or high attenuation. High attenuation, GGO. Ground glass opacity, what is it? There are two types of high attenuation, GGOs and consolidation. So what is it? Filling up the alveolar space with pus edema, hemorrhage, inflammation of tumor cells, plus thickened interstitium or alveolar walls, as seen in the fibrosis. So GGO may be either aerospace disease or maybe a part of fibrosis. ILD. Location is important. Upper zone predominant, respiratory bronchiolitis, pneumocystis girovicii pneumonia, lower zone UIP, NSIP, DIP, centrilobular distribution, hyperthermic pneumonitis, respiratory bronchiolitis. This is another good message to all of you. So low fibrosis, lot of fibrosis. This is treatable, this is not treatable. Prognosis of this is good, prognosis of this one is bad. So fibrosis decides the prognosis. Now mosaic attenuation. What is mosaic attenuation? You should know, all of you should know something about it. Mosaic attenuation is a term used to describe density differences. They are black lung, white lung. Then how do you distinguish which one is the pathological? You have to distinguish which one is the pathological. Radiologists would not decide. Now the physicians and the pulmonologists will decide. And MD medicine people, more than one third of you people are having respiratory now. So you have to become a pulmonologist first, then you become a physician. So you have to give the diagnosis. You have to know about it. If the vessels are visible, not visible in the black lung में नहीं दिखा, it seems to be abnormal. Examples being obstructive bronchiolitis or chronic pulmonary embolism.
chronic pulmonary embolism. But if the vessels are in the same, in the black field, vessels are there in the black field, it is infiltrative lung disease, the best example being pulmonary hemorrhage. So this is all example of mosaic attenuation. Lamb, this is a beautiful, this is all beautiful, is CT, HRCT of Lamb, a case of Lamb, young lady who suffered from there's a big pneumothorax, the ruptured cyst gave rise to big pneumothorax. She was from a childbearing age, and she was a case of Lamb. Cystic lung disease is very important. LIP, already I told you, LIP is nothing but NSIP plus cysts. HRCT pattern, how do you differentiate between emphysema and cystic disease? अभी हमने बताया था, figure भी दिया था. So you have to know, how do you differentiate? So these are the different examples: centrilobular tobacco abuse, paraseptal associated with centrilobular, panlobular alpha-1 antitrypsin in young persons deficiency, smokers, well-advanced emphysema. Cystic nematoceles found in pneumocystis jirovecii in HIV patients, PLHA patients. LCH, PLCH, pulmonary Langerhans cell histosis, very common in smokers. What are the common ILDs associated with, or cystic disease associated with smoking? 1, 2, 3, 4. Deepak? ILD is common. 70% ILD in IPF. There is a history of smoking. PLCH is one. RBILD is another one. Respiratory bronchiolitis. DIP is another one. One more. IPF already told. We already told about IPF. खत्म? रुक गया, बोल रहा नहीं जाएंगे आगे. And now zonal distribution is important. Zonal distribution, various DPLDs have a predilection for affecting either upper or lower zone. So remember a formula: upper lobe involvement, cassette P, cassette P. C for cystic fibrosis, A for ankylosing spondylitis, S for silicosis, S for sarcoidosis, E for anybody? P for tuberculosis, P for pneumocystis jirovecii. So you have to remember cassette P. What does the E stand for? Tell me. So similarly, finished. Sorry? I'm just finishing. So these are the patterns: upper lung zone, centrilobular emphysema, respiratory, bronchiolitis, sarcoidosis, LCH, chronic HP. So concomitant findings are very important. Presence of various concomitant images associated with lymphadenopathy, pleural effusion, pneumothorax, pleural plaques, and osseous lesions. They are helpful in differential diagnosis. So it's a big chapter. I can't give my deliberation only in 25 minutes or 30 minutes. So I hope I will be talking something more next time. Thank you so much.
Thank you so much. We're just putting. In the meanwhile, I'll just have the screen sharing on. We have Dr. Puneet Saxena joining us live. And yes, the chairperson, you can have your comments.
Nobody won. I have already given my PGs many a times at Patna.
Thank you, sir. It was a great deliberation, and we have learned a lot from you. Thank you.
In the meanwhile, we would like to felicitate our chairpersons and thank them as well. I request you to please just move outside the hall on the left-hand side. We have a special stage created for the chairpersons and the speakers. Yes, chairperson, please go ahead.
Thank you.
Yes, and on the screen you can see we have And on the screen we have Dr. Puneet Saxena. Dr. Puneet, can you hear us? हमारा अनम्यूट है ना अजित? हाँ कर दो. अजित जस्ट फॉर अ फ्यू सेकेंड्स स्क्रीन को ब्लैक आउट कर दे. वो फोटो लेना है उनको. ब्लैक कर दे स्क्रीन को. यस ताकि फोटो अच्छा आ जाए. हाँ परफेक्ट. नाउ यू कैन टेक अ पिक्चर. यस. Dr. Puneet, in the meanwhile, if you can hear us, we are just felicitating the speakers from the previous session, and then we shall get started with yours.
Sure.
Thank you so much. At the outset, if you could just check your microphone, if you could just say hello to everybody.
Hello.
Photo
Can you hear me? Good evening.
All right. Can we, Ajit, screen चालू कर दे. तो वो पूरा जूम का उन्होंने पूरा सेटअप चेंज किया इसलिए तो स्क्रीन ऑफ कर रहे थे. Yes, he's online. You can see him. That's why Dr. Puneet is also sharing his presentation. Yes, that's what. Thank you so much. With that, we would like to move to the next session. And can I request the chairpersons to please join us? Can I request Dr. Suresh Kushwaha, Dr. C.K. Das, Dr. Anand Sinha, Dr. Amrendra Kumar, Dr. Sudhanshu Jha to please join us as the chairpersons. And if we have Dr. Anand Sinha on the chairperson, we will have it on time, I guess. Dr. Puneet, thank you so much for joining in. Just wanted to let everybody know that the total time allotted for you is 20 minutes, out of which the timer will be set for 17 minutes. And we'll give you a buzzer 15 minutes, so you have 2 minutes to conclude after that. And then 3 minutes discussion. Over to the chairpersons for your comments. Camera chairpersons pe. Yeah.
Dr. Puneet Saxena is professor, senior professor and head of medicine at SMS Medical College, Jaipur, and he is a vice chairman of Rajasthan API, past secretary of Jaipur API, and organizing chairman of the Epicon 2022 at Jaipur. And he is member of so many associations. I request Dr. Puneet, please start your lecture on hyponatremia.
Thank you very much. Dr. Kushwaha is there, Dr. Jha, Dr. Amrendra, Dr. Sinha, all the chairpersons. And I thank Dr. Hemshankar Sharma, Dr. D.P. Singh, and Dr. Obaid Ali, and all the team Bihar of API, Dr. Kamlesh Tiwari, Dr. Thakur Sah, Dr. Amit Das. Unfortunately, I could not make it because of cancellation of flight. So, but it's so nice gesture that I have joined you ultimately, and I'll be speaking on hyponatremia. And since I'm not there physically, I may be allowed a minute or two extra for that to compensate my absence. So. I'll be speaking on hyponatremia. And why hyponatremia? I've been speaking on many forums on hyponatremia, and it's a very common and a pertinent problem. And as far as definition is concerned, we all know that if the sodium has to maintain a very narrow balance, and if it's less than 135, it is labeled as hyponatremia. And it's a very important and common problem these days, seen in almost 15 to 30% of hospital settings, especially in the intensive care units. And with the advent of so many chronic diseases and polypharmacy, this problem is going up and up. And varied etiologies of hyponatremia and so many formulas and equations to calculate and correct it it becomes a cumbersome job. But if you understand it fully, then it becomes much easier because it has grave prognosis if you don't control hyponatremia. It's perhaps the most common electrolyte abnormality in clinical practice, and you can divide them into the severity based on the levels. If less than 125, it's severe, 125 to 130 is moderate, and 130 to 135 is mild hyponatremia. And it has importance because severe hyponatremia can be deleterious for life, and rest too can be symptomatic, or it can have subtle symptoms. So further, you can divide it on the basically on the basis of onset. If it is less than 48 hours of duration, it is called acute hyponatremia. And patients with acute hyponatremia will develop neurological symptoms and signs because of cerebral edema induced by water movement. And it is more dangerous because there is no time for adaptation for body for this hyponatremia, and seizures, impaired mental status or coma, and finally death can come in if it is not addressed. On the other hand, if it develops slowly or more than 48 hours, then the brain has time to adapt itself, and normally you will find that it is less symptomatic because of generation of erogenic osmoles in the brains, which tries to maintain the oncotic pressure of neurons. So the chronic hyponatremic patients will not be symptomatic in mild or maybe even the moderate category, but when it becomes severe, then obviously it will be symptomatic, and it can have same symptoms and prognosis as acute hyponatremia. So if you we need to understand the pathogenesis of hyponatremia, because it's a narrow balance which is maintained by the kidneys, where it maintains the solute and the solvents, and it is inability of the kidney to excrete excess load of water intake, or that's why you will have the problems of the dyselectrolytemia. It's not only sodium, but other electrolytes can also fluctuate because of this dysfunction. Water intake depends upon the thirst mechanism. So it's basically the input and the output which matters. So thirst is also important, and it which is turned is stimulated by osmolality of the serum. And thirst, we all know the center rests in the hypothalamus, and the antidiuretic hormone ADH is the central hormone which is secreted from posterior pituitary, which maintains this thirst and the excretion of the water. It acts on the V2 receptor located in the basolateral aspect of the collecting duct cells. And sorry, it has moved. Collecting duct cells, which leads to aquaporin expression on the luminal aspect. And these pathogenesis is important because we are targeting aquaporin expression for treatment of hyponatremia or controlling ADH. So more and more we know about the pathogenesis, more are the targets amenable to the treatment. And if you see that hyponatremia, why it occurred, if there is persistent ADH stimulation, which can be seen in various situations. It can be normal with persistent ADH secretion in volume depleted patients, where the decreased volume counteracts the effect of hyposmolarity and ADH stimulation continues to occur. And the second situation is abnormal ADH secretion, which is the syndrome of AID-AH, inappropriate ADH release, which is the most common culprit for hyponatremia. We'll see later on. So if you classify hyponatremia, the first thing to see is the serum osmolality. If it is less than 280, then it is true hyponatremia. If it is more than 280, then it is not true hyponatremia. It's a pseudo hyponatremia, and where you can have a normal, or you can say isotonic osmolality, or you can have high serum osmolality. So pseudohyponatremia or true hyponatremia and translocational hyponatremia, these are the three terms which are used. And normal serum osmolality, we all know that is between 280 to 295. And true hyponatremia will have always osmolality of less than 280. And this is the equation which is shown over here, which we have been studying from our MBBS days, that how we can calculate the serum osmolality given the values of sodium, glucose, and blood urea nitrogen, which is very easy to calculate. Just few words about the pseudo or hyponatremia, or maybe isotonic hyponatremia. Why does it happens? Is when the level of the solutes like hypertriglyceridemia or increase in the plasma protein happens, as seen in multiple myeloma. What happens is the plasma water fraction falls below a certain level, maybe below 80%, and that is the reason why there is the false assessment of sodium and it leads to pseudohyponatremia. In other conditions also, it can happen where the renal failure happens and there is elevation of too much of urea basically, which can contribute to this pseudohyponatremia. Talking about translocational hyponatremia, or you can say it's a hypertonic or redistributive. Hypertonic means when the osmolality is more than 295. You have very limited causes for that. So if in cases of hyperglycemia, you will find it, or when you are administering solvents like mannitol to the patient, then the osmolality can go up and it can lead to a false sodium assessment, which is called as translocational hyponatremia. Coming to the true hyponatremia, which is associated reduction in osmolality, it can be further subclassified based on the volume status of the patient. It can be a hypovolemic, euvolemic, or hypervolemic. And if you see the first table, the hypovolemic can further be subdivided basis the presence of sodium of more than 20 milliequivalents in urine or less than 20. And based on that, you can narrow down yourself to the etiology of hypovolemic hyponatremia. If the urinary sodium is more than 20, then cerebral salt wasting, use of diuretics, salt losing nephropathy, ketonuria, and RTA is the cause. And if it is less than 20, then gastroenteritis, which is so common, and third space losses of fluid is responsible. But if you see the euvolemic causes, where the volume status is normal, and if the urinary sodium is more than 20, SIADH is the commonest cause. And please note that the SIADH contributes to almost 60% of the causes of true hyponatremia. So you need to be very considerate about this etiology. Then glucocorticoid deficiency, hypothyroidism, the use of drugs. The drugs list is so long, which we will see later on. But if the urinary sodium is less than 20, then primary polydipsia, consumption of too much of beer or any solvent which is devoid of the solutes or the electrolytes, you can say, that is the one. Exercise induced, like the marathon runners or those who play very vigorous sport, or the laborers who are working in the hot afternoon. So these people have this kind of hyponatremia. And on the last end, you have hypervolemic, where there is fluid overload. And we know the CHF, cirrhosis and nephrotic syndrome or renal failure, can have this kind of fluid overload. And again, you can differentiate between the etiology basis, the presence of urinary sodium of less than or more than 20 milliequivalents, as shown over here. If you see the etiology of true hyponatremia, uh, coming to the hypovolemic hyponatremia, the important cause is cerebral salt wasting, which needs to be differentiated with the SIADH, because what is commonly perceived as that if there is a central nervous system abnormality, then these two conditions, they can be a cause of hyponatremia, but they are entirely different. And we will come later on where we will see the difference between the two. But coming to the other causes like diuretic induced hyponatremia, thiazides are the commonest cause for amongst the diuretics for hyponatremia, as as against the conceived perception that the loop diuretics being strong can cause hyponatremia. That is not the case. And thiazide diuretics, especially in women, especially when they are initiated, can be cause of hyponatremia, and especially in the blacks, it has been implicated more as a cause of hyponatremia, whereas furosemide will not easily cause hyponatremia until and unless the fluid intake is less, or is there a superimposed intercurrent illness like sepsis. It will not cause. Mineralocorticoid deficiency can be a cause of hypovolemic hyponatremia, but there is increase in potassium when you have mineralocorticoid deficiency. That is a differentiating feature. And coming to the euvolemic hyponatremia, as I already, it is the most common variety where 60% of all causes is caused by this, and the SIADH is the most common cause. So majority of them is being attributed on this. The old criteria given by the Barter and Swiss in 1967 are still valid, and they were divided into the major criteria and the minor criteria for. But please note that SIADH is the diagnosis of exclusion. Even if their criteria are there, but it's a diagnosis of exclusion. And if you see these criteria, then we'll see the uh, major criteria, then decreased serum osmolality, euvolemia, urine osmolality of more than 100, urinary sodium of more than 40, normal thyroid and adrenal function, normal renal functions, exclusion of use of diuretics and other drugs, and no acid-base disorder. And then supporting criteria of uric acid less than 4 and BUN less than 10, FeNA, that is fractional excretion of sodium more than 1%, and failure to improve or rather worsening when you give isotonic saline, which is the most common practice as soon as the patient comes to the indoor setting with hyponatremia. We tend to infuse isotonic saline, and if the patient worsens, think of SIADH, and improvement of hyponatremia with fluid restriction, which is the mainstay of therapy, is suggestive. There is a long list of etiology of SIADH, CNS disturbances, malignancies, drugs, surgery, pulmonary diseases, HIV, then hereditary causes, idiopathic, exercise-induced, primary. So you can see that, and
एक
so
गोली ले ली
many
ना
so many diseases which
बस एक
are
ही गोली
responsible for admissions to the hospital can cause SADH. And if you see the drug list, all sort of drugs, anti-diabetic, anti-epileptic, anti-cancer drugs, antipsychotic drugs, painkillers, so hormonal therapy, and besides that, the miscellaneous therapy like interferon, bromocriptine, amiodarone, so many drugs can cause SIADH. So when we are dealing with IDH, we need to think of this exhaustive list also, that what can be the cause, and there can be different kind of pathogenesis for the SIDH based on the location of the defect. So we have to divide into type A, B, C, and D, and I will not go into the detail because clinically it is hardly significant that we know about it. But this is important differentiation between SIADH and cerebral salt wasting. Whereas the cause is inappropriate ADH secretion in SIADH, it is the brain natriuretic peptide in cerebral salt wasting. And hyponatremia are common in both. Urinary sodium is high in both. But please note in CSW, the blood volume or the circulating extracellular fluid is decreased, and BP is either normal to low, and the BUN creatinine ratio is increased. That means it shows signs of dehydration perhaps, and the plasma uric acid is therefore it also goes up. And in treatment, the normal saline is the treatment of choice for cerebral salt wasting along with fludrocortisone, whereas fluid restriction is the treatment of choice with SIDH along with the diuretic to shut off the diluted fluid. Exercise-induced hyponatremia. Marathon runners can sometimes succumb to
Just a
severe
gentle reminder,
hyponatremia
sir,
and can
we are
lead to arrhythmia
finished
and death.
15
We have
minutes.
seen that they have large amount of consumption of beer drinks, especially in the malnourished patient who don't eat properly, that they can develop because the capacity of kidney to excrete the extra solvent is surpassed, and there is dilution, and it finally leads to hyponatremia. Then low dietary solute intake also happens in the beer drinkers. If it is there, then probably the hyponatremia will set in. Primary polydipsia can be a cause. Then if there is too much of it, most of the time it is the cause is psychogenic, but there can be an organic cause also for polydipsia which we should look for. And again, the water load which is taken extra is cannot be excreted. Coming to the last category of true hyponatremia, that is the hypervolemic one, then congestive heart failure, cirrhosis of
Just a
liver,
gentle
and the
reminder,
renal
we are
causes
running
can
short
be
of time.
because there is expansion of extracellular volume. Coming to the diagnosis, drug and diet history, history of volume loss is important. Assessment of volume status is important, and patients with clinical signs of volume depletion should be seen in the clinical examination. And direct hemodynamic measurements can be the corroboration of the clinical impression. Then other causes like hypothyroidism and adrenal insufficiency should be looked for, and detailed examination as far as the CNS and the pulmonary system, which are the common. And drug list is important. This is the algorithm for diagnosis: measurement of serum sodium, serum osmolality, urine osmolality, urine sodium, then ratio of urine to serum electrolyte, fractional excretion of sodium, serum uric acid and urea concentration, and acid and base potassium balance. And finally, diagnostic challenge of saline infusion, whether it is the improving or whether it is decreasing, is this is the diagnostic algorithm or step-word approach, you can say, for the then thyroid profile, then brain imaging, imaging of chest, and maybe other causes. And coming to the last part of my talk is the management. So once you have subjected the patient to a diagnostic algorithm, then you come to the management and treatment of the underlying cause. Obviously, uh, should be the aim. Finally, an initial therapy, however, is to raise the serum sodium to avoid the deadly complications of hyponatremia. And prolonged therapy is required in patients with persistent SIADH, which cannot be diagnosed, or probably where the hyponatremia is a concern on a chronic basis also. So, hormonal replacement therapy in adrenal insufficiency or hypothyroidism, treatment of infections, meningitis, tuberculosis, cessation of ending drugs are some of the measures which will lead to correction of hyponatremia. And treatment finally depend on the volume status of the patient, duration of hyponatremia. As we have seen that acute hyponatremia is an emergency and needs to be treated on urgent basis, and presence or absence of symptoms, and finally the etiology of hyponatremia. Coming to the
Apologies.
true hyponatremic management, euvolemic hyponatremia. Acute hyponatremia is generally symptomatic because of risk of brain herniation is high. The rapid correction is needed, and so these patients had no time for brain adaptation. So in acute settings, 3% hypertonic saline along with maybe loop diuretics and vasopressin 2 receptor antagonist and water restriction has to be there. And in acute onset and moderate neurological symptoms, 3% saline only can suffice. And in the less severe symptoms, where there are no symptoms, you can treat them easily by vasopressin 2 receptor antagonist and water restrictions only. So, how it has to be given? Then 3% saline has to be given, and 100 ml boluses can be given
Dr. Puneet,
for over
can you
10
hear
minutes.
us?
Yes, please.
Yes, sir, the time is up. If you could sum up in the next 30 seconds,
Yeah,
please.
I'll just take a
Yes.
minute to sum it up. Right?
Yes, sir. Thank you.
So, yeah, so boluses of 3% hypertonic saline can be given repeatedly. And, sorry. The goal is to provide an urgent correction by 4 to 6 millimoles per liter to avoid brain herniation. And for mild to moderate symptoms, one can go easy. Pot restriction is one of the mainstays of therapy, and 500 to 1500 ml of fluid is recommended. And coming to the vasopressin receptor antagonists, we have been all using them. They are called aquaretics, and they reduce the number of aquaporin 2 water receptor. And conivaptan, tolvaptan, and lixivaptan, they are available, but we are using tolvaptan, and we all know that how does it act. It's an oral drug, and it's available for almost 15 years now. And conivaptan is a parenteral dual receptor antagonist. So coming to tolvaptan, 15 milligram dose can be escalated up to 60 milligram. Fluid restriction has to be there along with it. Then there are indications for that. It is to be avoided in hypovolemic hyponatremia, but can be given in euvolemic and hypervolemic hyponatremia. And then I'll skip the dosage and other things,
Yes,
the
sir.
pharmacokinetics and the content. And coming to the chronic setting, it is generally
Thank you.
asymptomatic. The treatment is almost similar, where fluid restriction, use of the same drug, loop diuretics, and you can use some, in some cases, urea mannitol and demaclocycline also. So besides that, the specific treatment of the cause is important in all the settings. And a few words about the ODS. If you correct hyponatremia very rapidly, then osmotic demyelination syndrome, which is characterized by the neurological deficits, especially the locked in state because of the involvement of the pons, can be a deadly situation. So don't overcorrect it. And in 24 hours, you don't aim for correction of more than 8 milliequivalents of 8 millimoles of sodium correction. So specific treatment has to be done for SIADH or maybe any other condition, depending on the primary polydipsia needs to be treated by a psychiatrist. Then hormonal deficiency needs to be corrected, whether it's thyroid or adrenal or any other cause of hyponatremia. And for exercise-induced hyponatremia, then it's an acute condition where again the boluses of saline has to be given, and precaution is always better. You need to train your
All right.
athletes and
So,
tell them about the
with
situation.
respect to
So
that,
coming to
yes,
the last slides,
please. Thank you.
the take-home message is that decreased serum sodium concentration is rather a common finding in population. The incidence is going up in the indoor settings, in the ICU settings, and we need to understand about the etiology and the polypharmacy, and to subject the patient to true diagnostic algorithm so as to reach the right cause, and then finally treat the urgency, and for long-term management, remove the etiology and the chronic hyponatremia. If it is very symptomatic, it's need to be treated as per the treatment of acute hyponatremia only. So with that, I finish my talk over here, and thank you very much for your patience. Thank you.
Thank you, Dr. Puneet Saxena, for excellent talk on hyponatremia. And due to of time, I request my co-chairperson to introduce next speaker, Dr. S.S. Daria, Sher Singh Daria from Jaipur.
Dr. Puneet, if you could stop your screen sharing. And
Yeah,
Dr.
sure. I'm
Daria,
doing
could you
that.
please
Just
start?
just give me a.
Yes. Just to let everybody know, the total time is 20 minutes, out of which 17 minutes is the timer. The buzzer will ring at 15 minutes and 3 minutes is for discussion. So, Dr. Daria, could you
Yes.
please start your screen sharing? We can see you. Only thing is missing is your smile and your presence over here. Yes, now that's there.
Sure, sure, sure.
Only the first slide. First slide should be
Yes,
the
उनका आ
introduction.
गया.
It should be the introduction. Yeah.
Yes. Dr. Daria says, मेरा introduction की कोई ज़रूरत नहीं है. आप सिर्फ मुझे time ज़्यादा दो.
Then it's okay. Then we can have 5 seconds extra.
Yes, Dr. Daria, could you please put it in the screen sharing mode, please? Sorry, the presentation mode. We can see it. When to suspect.
Yeah, it's on presentation mode.
पूरा full screen
Am
नहीं
I
दिख रहा है
audible?
सर. हाँ.
Full screen नहीं दिख रहा है.
Full screen नहीं दिख रहा है. सिर्फ हाँ.
Just a minute, just a minute.
Yeah, welcome Dr. Daria and Dr. Maheshwari. I am Dr. Puneet. Maheshwari is not able to
sir.
make up.
Good evening, sir. Namaskar.
Welcome. This
Pranam.
is Dr. B.B. Thakur.
Pranam, sir.
Good evening, sir.
Dr. Daria, please continue. Yeah.
Yes, sir.
Welcome from Dr. D.P. Singh. Yeah.
Yes, sir.
Try to share your screen again.
Yes, yes, yes.
यहाँ पर वैसे ऑर्गेनाइजिंग टीम ने काफ़ी सारे लोगों को बुलाया है फॉर इंश्योरिंग दैट द प्रेजेंटेशंस आर लोडेड ईजियर. सो अगली बार प्लीज़ थोड़ा सा जल्दी आइएगा भागलपुर, हम स्वागत करेंगे. क्योंकि फिर ये वाला जो हाँ फ्लाइट अगली बार चार्टर्ड फ्लाइट करके आएंगे, हमारा ही फ्लाइट होगा.
Yes, sir.
For that we are ready anytime, sir.
Yes, just start your screen sharing. कभी-कभी इसमें भी समय थोड़ा सा चला जाता है उससे.
Visible है sir?
Yes, sir, visible है. You can start.
Yeah, it's a full screen or what?
नहीं, it's not full screen. Could you just click on it?
दरिया full screen नहीं है, full screen करो.
Resume slideshow पे कीजिए. हाँ.
अब ठीक है?
नहीं, actually sir, I'll tell you what. Could you please press Alt Tab, Alt और Tab को एक साथ दबाइए. Alt
Or you can only press F5.
नहीं, F5
on the 10.
नहीं, actually कैसा है? It is already on, but it is in the background. So इसलिए वो नहीं दिख रहा है. Alt Tab करोगे तो you will go on to that tab. It will share that particular screen. Yes, now it is screen. It's visible. And now your time starts.
Okay, thank you so much, Honorable Chairpersons, for your kind introduction. So I'll be speaking on the suspect OSN clinical practice, when we have to suspect. So starting with the definition that OSA is a disorder where the upper airway obstruction during the sleep, which can be partial or complete, and changes in the air muscle tone during the sleep leads to a collapse of the upper airway, predominantly during the inspiratory phase of breathing. And during these episodes, the arterial oxygen saturation falls, and which can lead to the autonomic dysregulation. And the acute changes result over in time with chronic condition that affect the cardiovascular, pulmonary, and the neurocognitive systems. Here you can see the prevalence. The India rank among the third in OSA, and it is more almost 52 million people are affected with the OSA, and in percentage it's a 10% in age between 30 to 69, and the moderate and severe is almost 5% affected population in India. This is the prevalence. Here you can see that most in 50 to 59 years and the least in 18 to 29, and the males are affected 14.8 and females are 12.9%. This is the current consideration where you can see that obstructive sleep apnea having a different heterogeneity regarding the pathophysiology, the biomarkers, outcome, the anthropometric parameters, comorbidities, and the symptoms. So here is the pathophysiology with the therapeutic traits. In low arousal threshold, there is a airway mechanics where we have to lower the passive flow. And for that, we need a dilation of upper airway, while in the respiratory drive, there is a high loop gain, and in that case, we need the pharmaceutical influence on sleep or the breathing regulations. And on muscular compensation, then we need a stimulation or training of the upper way air muscles. These are the symptoms during the daytime and nighttime. You can see that in daytime there is a early morning headache, then daytime sleepiness, poor concentration, the irritability, the falling asleep during the routine activities, and in nighttime there is a loud persistent snoring, the witness pause in breathing by your partner, there is a choking or gasping of air, the restless sleep, and the frequent visits to the bathroom because of the OSA. So let's start with our case that Mr. Jamshan, who is a 45-year-old with a software developer having the BMI 30 with occasional smoking and occasional alcoholic. And chief complaint of that he is having excessive daytime sleepiness, loud snoring, and observed episode of breathing past during the sleep reported by his spouse. So there is a daytime sleepiness, there is a loud snoring, and witness apnea by his wife. So these are the childhood behavior: alcohol, drug use, age, smoking, male gender, menopause, the congenital defect, vitamin D deficiency, being overweight. So here in this case, you can see that the being overweight, the alcohol, smoking, and the male gender. Okay. So come to the diagnostic. The diagnostic procedure, the polysomnography is the gold standard for diagnosis of ASA, and it is the preferred approach to perform overnight pH in the sleep laboratory. However, it's a costly, may not be always available. Then in that case, we can use the home sleep apnea testing, which can be performed for patients who are having a high probability test for OSA and do not have other comorbidities. In this home sleep, there is an alternative medical test where there is a nasal probe to measure your airflow, a fingertip probe to measure your oxygen saturation level, and one belt around your chest and one belt around your abdomen to measure your breathing. Here you can see in this picture, this is the oximeter, this is the belt at your thorax, and the nasal cannula. So then Mr. Thompson went on a full night polysomnography in sleep laboratory, and that confirms the diagnosis OSA with apnea hypopnea of 28 events per hour, and the number of breathing pause per hour of sleep with, if it is more than 15, then indicative of the moderate to severe OSA. Then the second is the stop band questionnaire, by which we can ask the patients that whether they are having the OSA or not. This is a questionnaire based. In that case, if there is a no PSG, then we can go through that. In this stop, the S meaning, we ask the patient, or we give the questionnaire to a patient that do they often snore loudly, T for the tiredness, or for the has anyone observed that they have stopped the breathing during sleep, and P for the pressure, do they have a high blood pressure. And the bank B stands for BMI. If it is more than 35, then age over 50 years, and the neck circumference if it is more than 40 centimeter, and the male gender. So each one score point for positive response, and if there is a score between the 0 to 2, then there is a low risk. If it is 3 to 4, then intermediate, and if it is 5, then more or high risk. This is the short questionnaire again. Just a minute. Berlin questionnaire. Here there are 11 short surveys, and they focus mainly on the snoring, the daytime sleepiness, and the obesity, high blood pressure. In each category, the response are scored as a positive or negative, and if there is a 2 or more positive categories, indicate high likelihood of this sleep disorder breathing. In category 1, do they snore? Yes, snoring is very loud, louder than talking. How do they often snore? Has your snoring bothered some other or any other? In second category, they tired about the tiredness. In third, it is about the blood pressure. And third one is the Epworth Sleepiness Scale, the ESS scale. In this category, the list of 8 situations in which the patient rate tendency to become sleepy on a scale of 0, no chance of dozing, to 3, high chance of dozing, And when they finish the test, add up the values to the response, and if total score is based on the scale 0 to 4, then if slight chance of dodging, then 1, moderate is 2, and high chance of dodging is 3. And interpretation is that if it is 0 to 7, then it is unlikely that you are having a abnormal sleep, and 8 to 9 you have an average amount of daytime sleepless, 10 to 15 you may be excessively sleepy depending on the situation, and on 16 to 24 you are excessively sleepy and should consider seeking the medical attention. Mr. Thompson scored 15 on the ESS, and that indicates the excessive daytime sleepiness, and according to Stop Bank questionnaire there were high risk for OSA. In physical examination of Mr. Thompson, the neck circumference was 17 inch and the Malampatti score class 3rd and enlarged tongue. Now come to the case second, Mr. David Anderson with 65 year age, truck driver, BMI is 25, type 2 diabetic, history of smoking and binge drinking, severe daytime sleepiness, loud snoring. Then again here we can see the symptoms: severe daytime sleepiness, loud snoring, witness apnea and morning headaches. So on the ESS scale, the Anderson scored 18 and indicating severe daytime sleepiness, and Stop Bank also high risk for OSA, and physical examination also again the class 4 Malampatti score. So again he went on the PSG in sleep laboratory, and that confirms the diagnosis of OSA, and the AHI, the apnea hypopnea index, was 45 events per hour. Come to the complications of OSA. The OSA can cause the hypoxia and hypoxemia, and due to that there is a hyperactive sympathetic system which increase your catecholamines, the RAS system, and there is increase in the blood pressure. At the endothelial dysfunction, there is decrease in nitric oxide and increase endothelin 1. Systemic inflammation also is there because of this hypoxemia. Then you can have an increased TNF alpha, increased interleukin 6, and increased reactive oxygen species. And on metabolic dysfunction, increase insulin resistance and increase fasting and increase cholesterol. So overall increase for a stroke, heart failure, MIAF. This is a beautiful study which shows that the OSA also have impact on the hypertension, and if it is also the dose response effect of OSA on hypertensive severity, which challenge blood pressure control, so that with refractory hypertension they should be screened for the OSA. OSA also impairs our cognition. How it impairs that? Because of OSA, hypoxia and sleep fragmentation and other comorbidities, there is a psychiatric illness, mood and synaptic degeneration, there is a metabolic comorbidities, atherosclerotic cardiovascular disease, neurodegenerative changes, and they all impairs our cognition. This is the management of OSA. On the clinical feature, if the Epworth score is less than 10 and no comorbid condition, then we should go for a sleep study. And on the basis of AHI, whether it is a less than 30, more than 30, if it is less than, then alternate OSA therapy like your oral appliance and the upper way surgery, with assess your effectiveness with sleep study. And if it is more than 30, then we should start the positive airway pressure titration. If it is successful, then we should continue BiPAP therapy. And in comorbid condition where the Epworth is, then we should go for a OSA. Then again the BiPAP therapy is management of choice for the OSA. So mechanical obstruction can be saved by your weight reduction, because obesity, which is the most important risk factor for your OSA, and the almost prevalence of 40 to 90% between the BMI more than 40. And if we can reduce more than 5%, or ideally if more than 10% weight loss, then we can achieve, we can improve our severe OSA. So weight loss is not only associated with a decrease in AHI, but also with an improvement of hypoxemia. So the weight reduction intervention through the diet, we all know that we should take the less calorie diet, smaller quantities, timing of food intake, physical exercise by aerobic or interval training, muscle training, pharmacotherapy. Yes, nowadays the GLP agonist, which are like semaglutide and the GLP-GI tirzepatide, are being used for the weight loss, and bariatric surgery, which is almost claiming of more than 25% in your weight reduction. Another therapy, the positive airway pressure, where the continuous, the automatic, the BiPAP. The first line for most patient of OSA where the apnea index is scoring. Then these work as a pneumatic support that allows maintaining adequate airway patency above a critical value. And the observational data says that long-term BiPAP use decrease your blood pressure also, reduce your risk of stress, stroke and other cardiovascular event. And many RCT and meta-analysis shows that blood pressure, particularly in the uncontrolled hypertension. So CPAP is a favored initial therapy, and APAP is effective as CPAP with similar adherence and patient-reported outcome. And the BiPAP given to comorbidities where high PAP requirement more than 50 than or intolerance to CPAP and the APAP. There are some oral appliances also which are being used for the OSA, and one is the dual block mandibular advancement device. So that is also in moderate to severe obstructive apnea who refuse or are intolerant to the nasal continuous positive airway pressure. The positional therapy, there are some diverse devices which have been designed for your positional therapy: tennis ball, pillows, the bulky backpacks, and the position alarms. Sleeping in a upright position is also very effective in reducing your AHA and could be considered as a salvage solution in case of device problem where the lack of electricity or when conventional treatment fails. So the positional therapy can also be used as a part of multimodality therapeutic approach. Then come to the surgical options. In surgical, there is a maxillomandibular advancement, and the indication is where the complete lateral pharyngeal wall collapse and complete concentric vacuum collapse in your drug-induced sleep endoscopy. And this has to be proven the most effective surgical option in almost 85% of cases in severe. And the last one is the maxillary expansion, which is a predisposing factor for the development of OSA. The upper airway muscle activity, where the pharmacological approach by improving airway muscle tone with the serotonergic agonists, the cannabinoids, the affecting structure or anatomy, we can use the diuretic, weight loss inducing drugs, antihistaminic steroids, and vasoconstrictors. Increasing the ventilatory and stability, which reducing your drive, is the carbonic anhydrase inhibitor, the xanthines, and increasing your arousal threshold via the benzodiazepines, GABAergic, and trazodone. So improving airway muscle tone and reduction of the AHA by 62% in pilot trials. The drugs here, acetazolamide, which induce an almost 50% placebo adjusted AHI reduction in a small 2-week RCT. Zonisamide and topiramate also induces your weight loss by 9.4 to 10.2 respectively. So the treatment plan for Mr. Anderson, that they use the BiPAP due to severity of OSA and the presence of comorbidities, and weight management and diabetes control with collaborative care dietitian and endocrinologist and continuous follow-up. The last case, Mrs. Sarah Johnson, 35-year marketing executive, no significant chronic illness, occasional alcohol consumption, no smoker, BMI is within normal range. She also complains of persistent fatigue, difficult concentrating at work, and the occasional morning headaches. So the symptoms of OSA is the fatigue, the morning headache, and the partner's observation. Her partner reported loud and disruptive snoring along with the episode where Mrs. Johnson appeared to stop breathing followed by a sudden gasp for the air. So on ESS scale, she scored 14, and on stop bang there was a moderate risk, and physical examination Malampati was second.
Respected
So
Dr.
Mrs.
Sir,
Johnson,
last
yeah,
1 minute remaining.
within
Yes,
1 minute.
just a
So
general
Mrs.
reminder.
Johnson, underwent a home sleep apnea test to monitor her sleep pattern, and that home sleep apnea test results AHI of 18 events per hour, that confirming the diagnosis of mild to moderate OSA. So for Mrs. Johnson, their treatment plans were lifestyle modification, then sleep hygiene education, and the positional therapy to increase sleep on her side to minimize the impact of gravity on airway obstruction. So friends, my take-home message today is that OSA is highly associated with the metabolic syndrome or its core components, partly due to the common features of obesity, diabetes, but associations dependent of obesity, insulin resistance have been demonstrated, and the CPAP is considered first-line therapy for symptomatic and moderate to severe obstructive sleep apnea. And the recommended lifestyle modification including weight loss, counseling in overweight and obese patient, avoid the medication substance that promote relaxation of the upper way, and increasing awareness of and providing countermeasures for the risk of drowsy driving. Thank you everyone for your patient hearing.
This is a question to Dahiya sir. So my
Yes, sir.
question is, sir, apart from PAP therapy in OSA patients, what measures you are using in obesity hypoventilation syndrome?
Hello.
Obesity sleep hypoventilation syndrome. This type of situation is often associated with severe OSA cases. So, what is your experience regarding these type of cases in management apart from PAP therapy?
Sir, apart from PAP therapy, that we can use the lifestyle modification. If there is a BMI is more than 30 or more than 35, in that case, we can advise for the surgical management also. If BMI is more than 35, then bariatric surgery, which is more important in reducing the weight, that can reduce the hypoventilation syndrome. Apart from the PAP therapy.
Sir, are you using any kind of device in that cases? Because often we
Not right
say
now, I'm
that lifestyle modification is okay, but it is works around 85%. But it is a really difficult task.
All right.
No, I'm not using any device right now.
All right. Thank you so much, sir. We have our last speaker for the day. We have Dr. S.K. Madhukar, sir. I request him to please take the dais.
Thank you. Next speaker is Dr. S.K. Madhukar. He is MD Medicine, Fellow of Indian Chest Society, Director and Consultant Pulmonologist, Madhukar Clinic, Patna, and he speak on case-based interpretation of the lung function test. I request Dr. S.K. Madhukar, please start your deliberation.
Thank you, sir. Hi, everyone. It's my pleasure, privilege, and honor to be here with all of you. And at the outset, I thank you, organizing committee and scientific committee, Bapicon and Ezapicon, for having me in this wonderful scientific fest. Over the next 15 minutes, I'll be talking about interpretation of lung functions, which will be based on certain cases that we usually see in our clinics. All of us do perform some kind of lung function tests in order to detect and quantify the abnormalities in the respiratory system. And therefore, it's really critical to have a very organized approach, not only to perform, but also interpret these tests. The performance of the test is beyond the discussion here. What I'll be discussing today is the interpretation of those tests. To make it simple, let's understand how do we interpret these tests. Any lung function tests do not give us the diagnosis. The lung function tests give us the functional or physiological abnormalities in the airways and the lungs. And when we integrate the clinical data that we have into these physiological abnormalities, we reach to a differential diagnosis. So, whenever you see a lung function test, please do not jump to a clinical diagnosis. Let's see this approach one by one. This is the universal classification or universal interpretation of the lung function test algorithm. Suppose a patient whose FEV1 by FVC is normal. When we say FEV1 by FVC normal, it means it is above the lower limit of normal, or just remember one data, that is minus 1.645. If you remember this, minus 1.645, if the Z score is normal, that is minus 6.45, above than that, and FVC is normal, that is FVC above minus 1.645. If a patient has normal FEV1 by FVC ratio and at the same time has the normal FVC, how do we know these two data? Through the spirometry. When we perform the spirometry, we know what is FEV1 by FVC ratio, and then we know what is FVC. If these two data are normal, then we consider it a normal spirometry. Now consider this case. You have a flow volume loop, and then you have certain numerical data. Here, FEV1 by FVC Z score is above minus 1.645, that is FEV1 by FVC is normal. Then the second data that we look on is the FVC. Here, FVC is also normal. FEV1 by FVC normal, subsequent FVC normal. We usually interpret this data as having normal spirometry. Anyways, I'll just say what is there in the data. It has got normal FEV1 by FVC ratio, and it has got normal FVC, so it seems to have a normal spirometry. Just look at the flow volume loop. In the above the horizontal line is the expiratory loop. Below the horizontal line is the inspiratory loop. In the expiratory loop, in the terminal portion, what you are seeing is the slight concavity, very slight concavity. This means the patient is having some kind of a small airway obstruction. Whenever you see any concavity in the expiratory limb of the loop, it means the patient is having obstructive airway disease. More terminal it is, smaller the airway obstruction is. So there is a hint that we have a small airway obstruction despite having this normal spirometry. Now the point is, what should we do the next for these kind of patients? If you'll do the body plethysmography, it will only give an idea since the volume is normal. Putting another test which is going to measure the volume is not of our use. What we need to understand here is we need to measure the resistance. Large airway resistance, small airway resistance. Here it seems the pathology is in the small airway. So we will have to measure the small airway resistance. How are we going to measure the small airway resistance? There is only one tool, that is impulse oscillometry. Because body plethysmography will measure the large airway resistance. Subsequent body plethysmography is done. Here it shows clear-cut, highly elevated small airway resistance because R5 is above 135. Now, what we have understood by the lung function test, this patient has normal spirometry but elevated small airway resistance. Now integrate this data into the clinical data that we have. This patient is having recurrent episodic cough and breathlessness and is allergic to dust for almost 7 years. So this clinical data, when you integrate with the small airway resistance, the clinical diagnosis becomes bronchiolitis or chronic bronchial asthma. Second scenario, when you have a patient with FEV1 by FVC ratio which is normal, but here FVC is reduced. When FEV1 by FVC is normal, FVC is reduced, most of us think of restrictive lung disease. But let's understand this. Less than 50% of the patients who have normal FEV1 by FVC and reduced FVC have restrictive lung disease. More than 50% of the patients with this interpretation or with this data still have obstructive airway disease. Now, how will you resolve this? It's simple. You will have to measure lung volume by body plethysmography. Now, come on to this. This is the flow volume loop. There is a clear-cut concavity in the expiratory loop. So, this is obstructive airway defect. Consider FEV1 by FVC, which is normal. Here, FVC is low. So, FEV1 by FVC is normal, FVC is low. Your equipment has generated the interpretation as restrictive lung disease. But your flow volume says it seems to be obstructive lung disease. What would you do? Next step is lung volume. The lung volume. The TLC is decreased. When the total lung capacity is decreased, only interpretation is restrictive lung disease. It can never be obstructive. Here, the TLC is decreased. Here, TLC is decreased to a very lesser extent. See the residual volume very high. When the residual volume is very high, the loop is obstructive, diagnosis still becomes obstructive lung disease. And here, the patient's data. Breathlessness for 15 years, recurrent cough, nasal discharge, with obstructive pattern of lung disease, despite having normal FEV1 by FVC and reduced FVC. Diagnosis, chronic bronchial asthma. Third scenario, when FEV1 by FVC is reduced. Whenever FEV1 by FVC is reduced, the next data we look on is FVC. If FEV1 by FVC is reduced, but FVC is normal, only physiological abnormality is obstructive airway disease. It can never be restrictive. So, say this, the clear-cut concavity throughout the expiratory loop, clear-cut obstructive airway disease. FEV1 by FVC, normal. FEV1 by FVC, reduced. FVC, normal. Diagnosis, bronchial asthma, because the patient is having recurrent episodic breathlessness and cough with nasal discharge. And the last scenario, when FEV1 by FVC is reduced and FVC is also reduced. When FEV1 by FVC is reduced, FVC is also reduced. This is possible mixed disorder. Why possible? Because it can be solitary severe obstructive defect, or it can be mixed restrictive as well as obstructive defect. Let's consider this. Severe coving of the expiratory limb throughout in the flow volume loop. FEV1 by FVC reduced, FVC reduced. So it can be either mixed or could be obstructive only. Flow volume loop suggestive of obstructive. What would you do the next? Again, the lung volume. If TLC is reduced, it can be restrictive with obstructive mixed. But if TLC is normal, it can only be obstructive. TLC, greatly reduced. Here, the TLC is only 73% predicted. So, TLC is reduced. Diagnosis, mixed, restrictive, obstructive airway disease. And subsequently, this patient was found to have interstitial edema and diagnosed with dilated cardiomyopathy. So this patient is actually having COPD and dilated cardiomyopathy. If we wouldn't have judged this through the lung volume, we would certainly have missed a very important diagnosis, which could have been very fatal. So this is how we actually measure the lung function test. It's quite easy. but we really need to interpret these three data very cautiously. So, to conclude, we really have to have a very comprehensive approach. FEV1 by FVC, look at FVC. And if you are satisfied with these two, it's okay. No lung function. The only point where you are absolutely correct is FEV1 by FVC reduced, FVC normal, obstructive. In all other places, you really need to analyze, scrutinize with the help of other lung volumes. And when you have done this, integrate your clinical data to make a certain diagnosis. Thank you. Thank you so much for your patience listening.
Thank you so much.
Yes, sir. Yes, sure, sir. Body plethysmography is a test for the static lung volumes. When we perform the body plethysmography gives us only two primary measures. One is functional residual capacity, that is the lung volume at normal end expression, and the second is specific airway resistance. Now this functional residual capacity is important. With spirometry, the only volume that we cannot measure is the residual volume. That is the volume inside the lung after maximal expiration. So we can never measure residual volume with a spirometry. And if we cannot residual volume by spirometry, we cannot measure the total lung capacity with the spirometry, because total lung capacity is the sum of all the volumes. So how are you going to measure the total lung capacity? The body plethysmography gives us FRC. And from FRC, we ask the patient to have an inspiratory capacity maneuver. If you add FRC and IC, it gives TLC. So, and if you reduce vital capacity from TLC, it gives residual volume. So the only method to know functional residual capacity, residual volume, or total lung capacity is the body plethysmography. And if you integrate these two data, then only our lung function tests are complete. Without that, the only thing that we can diagnose through spirometry alone is the obstructive airway disease only when FEV1 by FVC is reduced and FVC is normal. Otherwise, you have to have plethysmographic lung volume tests.
Thank you so much.
Thank you, sir.
Thank you so much, chairpersons. Any last comments? इसके बाद we're going to have the free papers here. The scientific तो खत्म हो जाता है. So, yeah.
Dr. Madhukar, excellent talk, and I think he is the best speaker today for explaining the pulmonary function test so easy. We can understand the. I think he needs more clapping.
Big round of
Thank
applause.
you.
Yes.
Thank you,
now,
sir.
Can I request the
I'm
speakers
overwhelmed.
and the chairpersons to please join us just outside to be felicitated with a small token of appreciation. And we're just going to be having 6 papers right over here. And can I request the judges to please just come in the front on the sofa. We have Dr. Binay Chaudhary and Dr. Jyoti Prakash as the judges. Dr. Binay has the scoring sheet for both the judges and the 2 pens as well. Dr. Binay, यहाँ पर सामने बैठ जाइए और आसान रहेगा. And I'll give you a cordless mic. Dr. Jyoti Prakash, sir, yes, on the front. We're going to have the first presentation by Dr. Nidhi Priya. The total time allotted is 5 minutes. Dr. Nidhi, come right onto the stage. You can run up also, there's no problem, just don't fall. Yes, so ये तो scientific तो खत्म हो गया है. Free papers hall B में ज़्यादा थे, इसलिए हम यहाँ पर ले रहे हैं. Don't forget the scientific was on time, नहीं तो सब मुझे गुस्सा करेंगे. Dr. Nidhi is first, followed by Dr. Saurav Kumar. Can I request Dr. Saurav also to please be on the front? Dr. Solanki, number 3. Number 4 is Dr. Shiv Kapoor. Number 5 is Dr. Siddhanshu Dev. And the last one is Dr. Akhilesh Kumar. Am I right? सब इधर आ जाओ सामने. वो समय लगता है ऊपर स्टेज पे चढ़ने के लिए, वो भी हमें बचाना है. ठीक है? 5 minutes. Judges ready? This time I should just wait. Let the judges be ready, na? Yes. Yes. One second. Dr. Jyoti, अभी निधि क्या ही कर सकते हैं? Then we can slowly. हाँ. Dr. Nidhi, you can start.
I am going to present a case report on neuromyelitis optica.
हैंग हो गया क्या? वहां पर तो दिख रहा है. एक सेकंड. सब इतने सारे चालू रखे हैं ना. वेट, इसको क्लोज कर. Alt F4 भी कर दे. शॉर्टकट भी नहीं लगा. सबको ऑफ कर दे पहले अजित. स्विच ऑफ ऑल द प्रेजेंटेशंस. बहुत सारे खुले हैं. हाँ 2 मिनट. नहीं हो गया 2 मिनट. हाँ नहीं बट रहने दो सर. ये आपका नहीं ना. ये नहीं है ना. यही है. Is this the one? Yeah. Done. सामने लाइट. Done. Timer reset कर दे. Yeah, you can start.
Neuromyelitis optica is also known as Devick's disease, is an idiopathic severe demyelinating disease of the CNS that preferentially affects optic nerves and spinal cord. It is characterized by severe optic neuritis and transverse myelitis occurring either simultaneously or sequentially after variable period of time. It is more frequent in women than in men, with female is to male ratio being 9:1 and typically begins in adulthood with mean age of onset at 40 years but can arise at any age. It shares a number of clinical and radiological features with multiple sclerosis and hence is easily misdiagnosed as multiple sclerosis as characterized by relapses. In NMO, oligoclonal bands are usually not detected in CSF. The most important lab finding is aquaporin 4 IgG antibodies positivity, which is diagnostic of NMO. Case report. A 25-year-old female presented to medical emergency with complaints of weakness of both the lower limbs since 4 days and blurring of vision since 10 days. This was preceded by headache, fever, and vomiting 15 days back. There was no involvement of any bladder bladder, sphincter, and bowel. She had previously been well with no known chronic medical condition. On physical examination, her higher mental functions were normal. All cranial nerves were grossly intact except for the optic nerve. Both pupils were dilated and sluggishly reactive to light. There were no signs of muscle wasting. All the deep tendon reflexes were brisk and ankle clonus was also noted. Plantar reflex was bilateral extensor. Power in both lower limbs was 3/5 and in both upper limbs was 5/5. Tone was increased in all the limbs. All modalities of sensations were intact. Ophthalmoscopic examination revealed atrophy of both the optic discs. MRI brain with orbit showed atrophy of left optic nerve. MRI spine revealed multiple intramedullary T2 hyperintense lesions in upper cervical and upper dorsal spinal cord. Serum aquaporin 4 IgG antibodies were found to be positive. CSF examination revealed protein levels of 41 mg per cent, sugar levels of 81 mg per DL 5 nucleated cells with lymphocytes being predominant, and no oligoclonal bands were detected. Complete blood count, liver, kidney, and thyroid function tests, electrolytes, and vitamin B12 levels were all normal. ANA was negative. With the help of clinical and lab findings, the patient was diagnosed neuromyelitis optica according to the diagnostic criteria. Patient was started on methylprednisolone pulse therapy. Following this, her symptoms of weakness and blurring of vision started improving, and she was discharged on oral prednisolone and azathioprine. Neuromyelitis optica is an aggressive inflammatory disorder which is characterized by recurrent attacks of optic neuritis and myelitis. Attacks of optic neuritis can be bilateral and produce severe visual loss, which is uncommon in MS, and myelitis can be severe and transverse, which is again rare in MS and is typically longitudinally extensive, which involves 3 or more contiguous vertebral segments. In contrast to MS, progressive symptoms typically don't occur in NMO. The core clinical findings include optic neuritis, acute myelitis, area posterior syndrome with intractable vomiting or hiccups, acute brainstem syndrome, symptomatic narcolepsy or acute diencephalic clinical syndrome, symptomatic cerebral syndrome with NMOSD, typical brain lesions. Up to 40% of patients have a systemic autoimmune disease like SLE, Sjogren's syndrome, Pianka vasculitis, Hashimoto thyroiditis. Onset in some cases may be associated with acute infection with varicella zoster, Epstein-Barr virus, HIV, or tuberculosis, and rare cases appear to be paraneoplastic, which is associated with breast, lung, or other cancers. Autoantibodies against aquaporin 4, which is a water channel protein, and intensively present at the astrocytic protrusions, is suggested to be responsible for the pathogenesis. Lennon et al. Reported that the aquaporin 4 IgG positivity shows 73% sensitivity and 91% specificity in patients with clinically NMO suspected patients. Treatment includes the acute attacks are treated with high-dose glucocorticoids. That is, methylprednisolone is given for at the dose of 1 gram per day for 5 to 10 days, followed by prednisone taper. For prophylaxis against relapses, mycophenolate mofetil, rituximab, and combination of glucocorticoids with azathioprine can be given. There are also approved monoclonal antibodies for attack prevention, which consist of eculizumab, inebilizumab, and sertalizumab. Conclusion is early and accurate diagnosis of NMO is important, as it is a disease with a course with severe sequelae, and for this reason both the acute and maintenance therapies are important. NMO has to be differentiated from its alternative diagnosis like MS, as they share many clinical and radiological similarities. In the acute period, very good results may be obtained with the pulse steroid therapy. Management of both acute and chronic phases of disease and the significance of the strict patient-physician collaboration in the follow-up patient period should be emphasized. Thank you.
Thank you, Dr. Nidhi Priya, for a nice presentation.
One
we are dearth of time,
maximum,
so
yeah.
I don't think there should be any question.
So we have Dr. Saurabh Kumar next.
Thank you.
Yes. अंकित अजित अजित छोड़ दे उसको छोड़ दे पेज बाय पेज कर इस पे जैसे ही कर देंगे ना hold on don't worry presentation mode yeah
good evening everyone. I'm going to present my paper on prognostic predictor of 30-day outcome in patient with non-traumatic intraparenchymal hemorrhage. Stroke is a sudden onset focal neurological deficit.
डुप्लीकेट कर देना पूरा एक्सटेंडेड डेस्कटॉप मत कर
So I am going to present the paper on prognostic predictors of 30-day outcome in patient with non-traumatic intraparenchymal hemorrhage. Stroke is a sudden onset focal
डुप्लीकेट की जगह पे वापस एक्सटेंडेड पे जा रहे हो लाइव ही रखना डोंट इसको हमारा चेहरा मत दिखा वो ही दिखा स्विच कर दे वापस से
So stroke is a sudden onset focal cerebral dysfunction due to vascular disease of the brain. Around 99% of stroke are arterial in nature, out of which 85% are infarct and 15% are hemorrhage. The aim of the study was to evaluate the prognostic factors in predicting 30-day outcome in patient with hemorrhagic stroke admitted in DMCS Darbhanga. For that purpose, 20 patients with acute hemorrhagic stroke admitted in general medicine ward DMCH was from September 23 to October 23 were evaluated for prognostic significance of mean arterial pressure, GCS at the time of admission, volume of bleed, location of bleed, and intraventricular hemorrhage. For this, patient with non-traumatic intraparenchymal hemorrhage was included, and patient with history of trauma, subarachnoid hemorrhage alone, previous history of intraparenchymal hemorrhage, intraventricular hemorrhage alone was excluded. Following data was collected for the patient: mean arterial pressure, GCS at admission, volume of bleed, location of bleed, presence or absence of intraventricular hemorrhage. For that, 20 patients were studied. Out of that, 11 patients died in first 30 days, and 9 patients survived after 30 days. During evaluation of mean arterial pressure, 5 patients was found to be having mean arterial pressure more than 145, out of which 4 patients died within 30 days with mortality rate of 80%. 15% were having mean arterial pressure less than 145, out of which 7 patients died. Mortality rate 46.66%. GCS at the time of admission for 11 patients were less than 8, out of which 10 patients died, leading to mortality rate of 90%, while 9 patients were having GCS more than 8, out of which 1 patient died in 30 days, leading to mortality rate of 11.11%. Volume of bleed, 10 patients were having less than 10 patients were having less than 30 ml of volume of bleed, out of which 2 patients died, 20% mortality. 7% were having 30 to 60 ml of bleed, out of which 6 patients died, 85% of mortality. 3 patients were having more than 60 ml of bleed. All patients died, 100% mortality during the study period. Location of bleed, 11 patients were having gangliocapsular bleed, out of which 6 died, 54% mortality. 4 patients were having lobar bleed, out of which 2 patients died, 50% mortality. 3 patients were having thalamic bleed, out of which 1 died, 33% mortality. 2 patients were having brainstem bleed, all died, 100% mortality during 30 days. 9 patients were having intraventricular hemorrhagic extension, out of which 7 patients died, 77% mortality. 11 patients were not having intraventricular hemorrhage, 4 patients died, 36% mortality. So during this study of 20 patients, 5 patients were having mean arterial pressure more than 145, 4 died, 80% mortality. 11 were having GCS less than 8, 10 died, 90% mortality. 3 were having volume more than 60 ml, 100% died, and 9 were having interventricular extension, 7 died. So in conclusion, we can say that stroke with intraparenchymal hemorrhage with mean arterial pressure less than 145 mm of Hg, GCS more than 8, volume of bleed less than 30 ml in absence of intraventricular hemorrhage has more chance of survival after 30 days. Thank you, sir.
Thank you so much. As we have very less time, can I request our next speaker, Dr. Solanki, to please join us on the stage? Thank you. Dr. Solanki, could you just let us know your full name?
Solanki Lato.
Lato.
Yes.
Okay.
Good evening, everyone, especially the judges, and to all my colleagues. Today I'll present a case on beta thalassemia intermedia, typical presentations, guided by Dr. K.K. Jha, sir, professor, and Dr. G.N. Dubey, associate professors, DMCH, Darbhanga. Introduction. Beta thalassemia is a genetic or inherited disorder that is sometimes called Cooley's or Mediterranean anemia, or sometimes we call thalassemias. Beta thalassemia intermedia is a clinical condition of intermediate gravity between beta thalassemias minor and beta thalassemias major. Clinical complications of thalassemia intermedia are splenomegaly, extramedullary erythropoiesis, iron accumulation, leg ulcers, thrombophilia, and bone abnormalities, and can be managed via fetal hemoglobin induction, occasional blood transfusions, chelation therapy, and stem cells transplantation. Given its clinical diversity, thalassemia intermedia patient require tailored approach to therapy. This is the diagram that shows genetic transmission of beta thalassemias from parents to children. This one in 4 chance can be affected to the children by the parents' carriers. There's a case reports of the 13 years old female patient, Muslim by religions, presented to the DMCH emergencies with symptoms of palpitation, generalized weakness, pain abdomen, and generalized body aches of a non since childhood. Patient only had a history of similar complaint in the past with mild to moderate anemia since childhood from the age of 2 years, and the patient was being managed conservatively. Patient was not a known case of any tuberculosis, diabetes mellitus, epilepsy, hypertension. No surgical history in the past also. Treatment history, patient received occasional blood transfusions since childhood, and the patient last blood transfusion was on November last year, 2022. There's no family history, no significant family history is there. General examination, patient is conscious, oriented, and cooperative. Thin bill, pallor is present. Icterus, no lymphadenopathy and no edema. Pulse rate of patient is 104 beats per minute. BP is 100 by 70 milligram mmHg. Respiratory rate is 20 per minute. Body temperature 98, CO2 98% room air. On systematic examination, respiratory examination shows clear lungs with no adventitious breath sounds. Cardiovascular examination shows normal S1, S2. Abdominal examination shows mild to moderate splenomegaly is there. Central nervous system is within normal limits. The investigation routine blood test shows the hemoglobin is 7.1 gram per deciliter. MCV is 72.6 femtoliters. MCHC is 25.2 gram per deciliters. RBC is 3.83 millions per microliters. RDW is 30.1%. IRF is 42.2%, and platelet counts is 1,60,000. Peripheral blood smear shows reticulocyte counts is 1,37,000. Microcytosis, anisopoikilocytosis, normoblastemia 40%. Basophilic stipplings, target cells positive, indicates hemolytic anemia. Serum LH levels of raised 280 international unit per liter. Ultrasound of abdomen also was done. It shows splenomegaly with size of 15.4 centimeters. This is a complete blood count. USG abdomen. HPLC was done, and it shows fetal hemoglobin is 22.2%, and adult hemoglobin is less, 24.6%, and HbA2 is 44.4%. Liver function test also, serum bilirubin shows 3.2 milligram. Serum bilirubin by direct is 0.3 milligram per percent. Serum bilirubin indirect is 2.9 milligram percentage. This is a HPLC report. Diagnosis on the basis of the clinical manifestations and hematological evidence. Patient was diagnosed as a case of beta thalassemia intermedia. Treatment and management, genetic screening of the carriers. Counseling should be done and to prevent the occurrence of the disease, and antenatal diagnosis of the fetus to prevent further complication later in life. Blood transfusion and iron chelation depends on the hemoglobin level and serum ferritin for iron overload. Hemopoietic stem cell transplantation and splenectomy if there is extravascular hemolysis and hypersplenism. Other treatments like hydroxyurea, epoetin alpha, diprotein gene therapy can be tried to reduce the frequencies of blood transfusion, but the mainstay of treatment is beta thalassemia intermedia is blood transfusion. Conclusion, beta thalassemia intermedia must be diagnosed early as possible due to serious complications like pulmonary hypertension, extramedullary hematopoietic pseudotumors, bone disorder, endocrinopathy, thrombosis, cerebrovascular disease like ulcer, cholelithiasis, splenomegaly, iron overload, and liver complications, and must be prevented before it occurs. This is why a low index of suspicion should be kept in mind. The only way to reduce the public health burden remains premarital screening and adequate genetic counselings and early diagnosis and management. Thank you.
Thank you so much. Our next speaker is Dr. Shiv Kapoor.
Good evening, everyone. Myself, Dr. Shiv Kapoor, PG student, Jawaharlal Nehru Medical College, Bhagalpur. I am going to present a case of hypersensitivity pneumonitis, which can mimic idiopathic pulmonary fibrosis and other interstitial lung disease. Hypersensitivity pneumonitis is an interstitial lung disease mediated by aberrant cellular and humoral response to various inhaled antigen in susceptible individuals, resulting in inflammatory and fibrotic disease of lung parenchyma and small airways. Symptoms include cough, shortness of breath, and fatigue. SP is the commonest ILD with prevalence of 47% as reported in India. Overall incidence of SP is 0.3 to 0.9 per 1 lakh individuals. According to older classification, SP is classified into 3 categories, which is acute, subacute, and chronic. Newer classification of SP is classified into 2 categories, non-fibrotic, which is purely inflammatory SP, and fibrotic SP, which is maybe mixed inflammatory and fibrotic or purely fibrotic SP. Etiology of hypersensitivity pneumonitis. Disease probable antigens source, farmer's lungs. Probable antigens may be thermophilic actinomyces, Aspergillus species. Source, moldy hair. Bird fanciers disease. Probable antigens, bird protein immunoglobulins. Source, feathers, dropping serums. Humidifier lung. Probable antigen, thermophilic actinomyces. Hot tube lung. Probable antigen, non-tuberculous myobacteria. Hot tube lungs. Patient details. My patient, Muhammad Alamgir, 17-year-old male resident of Kishanganj, Bihar. By occupation, he is a student, belongs to low socioeconomic status. Patient came to the respiratory emergency room of Jawaharlal Nehru Medical College, Bhagalpur, with complaint of shortness of breath since 2 months and fever since 20 days, cough since 20 days. History of presenting illness. Patient apparently asymptomatic 2 months back. He experienced shortness of breath initially on exertions, gradual in onset, slowly progressive to shortness of breath on walking up a stair, and SOB not get relief even on rest. No any history of wheezing, chest tightness, orthopnea, and no seasonal and diurnal variation of symptoms present. He had history of cough for 20 days, persistent in nature, mostly productive, and sometimes with bacterial nature of expectorant. No any history of diurnal and seasonal variations or postural variations. He had a history of fever for 20 days, gradual in onset and low grade. Not associated with chills and rigors. Fever used to relieve on taking medication. Negative history. No history of any drug intake, exclude drug-induced lung disease. No history of weight loss, loss of appetite, night sweats, chest pain, exclude TB. No history of any previous hospitalization for any cause. No history of systemic disorder, exclude collagen vascular disease. Past medical history. He had history of cough and shortness of breath and got diagnosed tuberculosis in 2020, 21, 22. He took ATT for 6 months every year from private clinic. Family history and personal history. No any family history of hypertension, diabetes, mellitus, TB, and genetic disorder. Non-smokers and non-alcoholic. He works in poultry farm since 5 years. On general examinations, projecting finding, clubbing, grade 2, on examination saturation or O2, 83% on room air. This is clubbing. On respiratory examinations, inspections, palpation and percussion. Positive find on auscultations, bilateral fine crackles, या velcro crackles present. Abdominal examinations, abdomen soft and non-tender, no organomegalis. CVS examinations, S1 hearts on 1 and 2 here with no murmur. CNS examination within normal limit. On investigation, PFT pulmonary function test. Spirometry showed very severe restrictions. Routine blood investigations. Initially, CBC leukocytosis present, KFT, LFT normals, viral markers are negative. Test for antibodies. Total IgE antibodies normal. Total IgG for poultry antigens increased. Sputum for examination. Sputum AFB and sputum negative. HRCT thorax. In early stage of disease, slight ground glass opacity, septal thickening, ill-defined centrilobal nodular and mosaic attenuations present. HRCT report after 1 month corticosteroid therapy. Ground glass opacity present, septal thickening, quartz reticulation, honeycombing present, mosaic attenuations. This was the report. Broncho alveolar lavage fluid analysis.
Dr.
Done.
Shiv, the time is up. If you could conclude. Yeah. Go to the conclusion slide.
Final diagnosis. Based on the exposure history, clinical finding and investigation, this is the case of mixed SP, maybe fibrotic and inflammatory. Closest differential diagnosis is idiopathic pulmonary fibrosis, idiopathic non-specific pneumonia, tuberculosis and sarcoidosis. Treatment, avoiding exposure to the causative allergens, irritants. Corticosteroid-like treatment, corticosteroid-like prednisolone. Conclusion, steroid is the drug of choice in SP and non-specific interstitial pneumonia. But in some cases, after giving 1 month of steroid therapy, there is no any radiological resolution. Yeah, even got burst. So we should wait for 1 or 2 months to see whether ILD is same. Yeah, it will get changes. Thank you.
Thank you so much. Next we have Dr. Dev. Dr. Sudhanshu Dev. You can get started. Yes.
Good evening, everyone. I am Sudhanshu Dev, and I'll be presenting a paper on hypoparathyroidism with basal ganglia calcification. Parathyroid hormone plays a crucial role alongside vitamin D in regulating serum calcium levels through direct actions on the bone and the kidneys, as well as indirect effects on the gastrointestinal tract. Insufficient PTH secretions leads to the development of hypocalcemia. Hypocalcemia resulting from hypoparathyroidism can manifest across a spectrum, with mild cases often showing few or no symptoms, while severe instances may lead to life-threatening conditions such as seizures, refractory heart failure, or laryngospasm. The clinical manifestations are influenced not only by the severity of the hypocalcemia, but also by the rate of its development and the chronicity. Here we have a case report of a 28-year-old female who presented with burning sensation in hands and feet for 1 year, cramps in the legs and feet for 1 year, and a seizure, few episodes in 6 months. So a 28-year-old female presented with the recurring episodes of abnormal movements involving the jerky motions in all the 4 limbs associated with the tongue biting. These episodes had a duration of 2 to 3 minutes each, followed by a subsequent period of clouded consciousness lasting for a few minutes. She started to experience these seizures episodes 6 months back. Till now, she had 6 to 7 such episodes. She had complained about burning sensation. She had also complained about the burning sensation of the fingertips and feet since 1 year, and cramps in the legs and feet for the same duration. There is no significant past history. There is no family history. She's on mixed diet. She's married with 2 children, and she's having no addiction. There is no history of neck surgery or neck radiation. She's on antipsychotics for 2 years, and she's having the regular menses. On examination, pulse rate, blood pressure, respiratory rate, and SpO2 were found to be within normal range. on inflating the sphygmomanometer cuff above systolic blood pressure for 2 minutes, there was a painful spasm of the hand, that is the Trousseau signs. CNS examination, at the time of examination, she was conscious and oriented to time, place, and person. Motor and sensory examination were within the normal limits. Pupils were equal and reactive to light. DTR and plantar were normal, and the fundoscopy reports were normal. Other systems were within the normal limits. So, this is a case of a 28-year-old female patient with a known case of psychiatric illness with complaints of paresthesia of hands and feet and cramps in legs with multiple episodes of seizures. So we ordered